Very good evening to all. So, I welcome all of you to this rapid revision physiology session with me, Dr. Abhirami, Faculty of Physiology. The first step is always the hardest. So, I'm sure all of you might have crossed so many hardest steps, and now you have very few days for your exams. You are very close to success, 2 3 days to go. So at this point, I find many students messaging me saying that, ma'am, I'm feeling very scared, I'm feeling very tensed, very upset, feeling very down because we have very few days for the exam and feeling very stressed. So I thought we will start this session with this small story, a cutie story for you. So this is about the poor deer there, the pregnant deer, which is about to give birth to the baby. So look at that deer. It is surrounded by on all sides by different types of danger. On one side by the hungry hunter, on one side by the hungry lion, and on the other side there's the forest fire there, and on the other side the flowing river. So the poor deer, it didn't know what to do. It's so scared that it kept calm and quiet. Suddenly what happened? There was a big lightning. The lightning struck the hunter. The hunter became blind and his arrow had missed and it struck the hungry lion there. The lion was shot dead and there was heavy rain and the forest fire was put off. And now the deer is free on all sides and it happily gave birth to its baby. I'm sure most of you are in this stage only, blocked on all sides, so stressed, not knowing what to do. So take my words, sudden magic will happen during your exams. And suddenly you'll find when you look at the questions, excuse me, you'll find that when you look at the questions, you'll find that answers will pop out from all parts of your brain. Answers are stored in all parts of your brain. They'll come out like that, and you'll be able to answer every question right, and you'll be able to get through your exams. What is this magic which is happening? It does not happen all of a sudden. This magic is nothing but all your hard work, your efforts that you have put in, your persistence, your confidence, all your sacrifices that you have done. This will all give you that magic, and definitely all of you will be able to get through your exams. So, wishing you all very success in the following exams. We'll go on to the session. Excuse me. So, I thought we'll start the session with 2020 August FMG pattern questions first. Next, we'll move on to 2020 December FMG pattern. And after that, chapter wise, we'll have a very crisp discussion about the important topics. So, since it's a 2 hour discussion, we'll try to keep it as crispy as possible. Okay? Yes. So, over to the first question. See if you can answer this question. Very, very, very easy question that was asked in your August 2020 exam. Yes, anybody for the answer? Yes, what is the answer? Why nobody is answering? Hormone involved in milk ejection. A, very good. Chakri, Shakrid, Mugil Namashwayam, Atharva, very good. All of you are right. Oxytocin. See, the common mistake that you do here is you confuse with prolactin. Don't confuse with prolactin because prolactin produces lactation. That is why it is called as prolactin. Prolactin produces lactation. That's why it's called as prolactin. And oxytocin ejects milk or it oozes milk. Ejects milk or it oozes milk. So the answer for this question is oxytocin. Don't get confused with prolactin. So look at the milk ejection reflex. So what is this milk ejection reflex? See, when the baby sucks from the mother, oxytocin levels from the mother's brain increases. So this increases oxytocin levels. And this oxytocin acts on the milk ducts. The milk ducts widen and the muscles around the milk cells contract due to oxytocin. And this ejects milk and milk oozes out. And when more milk comes out, the baby sucks more. So the baby sucks more. When baby sucks more, the love of the mother for the baby increases. Therefore, the love hormone oxytocin also increases. This cycle keeps on continuing until the baby's stomach is filled with milk. So this is called milk ejection reflex. Don't confuse with prolactin. Prolactin only produces milk. It does not eject milk. Let's move on to the next question. Thyroxine has maximum affinity for which of the following? Yes, what is the answer for this? Again, a very direct question. Yes, Shahid, very good. Pro for pro. So I think it's getting late. If we wait for the answers, I'll just move on. If there's any query, we'll come back to that. Yes, very good, Shahid. Thyroxine binding globulin. So the answer is thyroxine binding globulin. So what are the binding proteins of thyroid hormones? Where is thyroid hormone produced? It is produced in the thyroid gland. In thyroid gland, you have follicular cells, and in between the follicular cells, you have colloid material. The actual synthesis of thyroid hormones occurs in the colloid material, and these thyroid hormones are stored in the follicular cells. And whenever needed, they can be released from the follicular cells. So they can be stored for nearly 2 to 3 months. And whenever needed, they are released into the blood. And when they are released into the blood, they bind to certain proteins. So thyroxine binding globulin or thyropexin binds 75% of thyroid hormones. Next, we have prealbumin or transthyretin, which binds 20% of thyroid hormones. And then we have albumin, which binds 5% of thyroid hormones. So maximum binding is thyropexin or thyroxine binding globulin, and least binding is albumin. So very direct question. Yes, this is a very interesting question that was asked in August exam. In the ECG given below, what does AH interval indicate? So first of all, you should know what is this ECG. This is a special type of ECG called as His bundle electrocardiogram, His bundle ECG. So we'll see what is that first. So what is this His bundle ECG? In heart block patients, if you want to know exactly the site of block, so what cardiologists do, they take a catheter and they have an electrode at its tip and it's inserted through a vein. It goes to the right side of the heart and they place the electrode very close to the tricuspid valve, somewhere near or around the AV node. This is called His bundle ECG. So when you place an electrode like this and you record an ECG, it's called His bundle ECG. And the recording of the His bundle ECG will look like this. It will give you A deflection, H deflection, and V deflection. So what is this A deflection? When the AV node is activated or when the electrical impulse passes through the AV node, you get A deflection. When it passes through the bundle of His, H for His bundle, you get H deflection. When it passes through the ventricular fibers, you get V deflection. So this is called His bundle ECG. Along with his bundle ECG, a normal ECG is also recorded. So you can see a normal ECG here. When you club both, when you club a normal ECG and a his bundle ECG, you get three intervals. So what are the intervals? See, in a normal ECG, the waves are P, Q, R, S, and T. So let's take the P wave first. So when we club this both, we get certain intervals. PA interval. So what is this PA interval? It is the conduction time when the impulse is being conducted from SA node to AV node, because P wave is due to atrial depolarization. So PA interval, it is the conduction time from SA node to AV node. AH interval. AH interval is when the electrical impulse is conducted through the AV node. You get AH interval through conduction through AV node. And HV interval. HV interval is when the impulse is conducted from the bundle of His through the fibers. So from his bundle through ventricular fibers, you get HV interval. So these are the three intervals. And in the question, they had asked about, I think, AH interval. Yes. So what is AH interval now? Conduction through the AV node. So this is a really very interesting question, more of a clinical applied question, because all of us know what a normal ECG is, but this question emphasizes on the importance of a special type of ECG called his bundle ECG. Next question. A 60-year-old patient has right-sided homonymous hemianopia with macular sparing. So the point to be noted is macular sparing. Locate the neurological site of lesion in this patient. So what is this macula first of all? Yes, what is the answer for this? Yes, can you give me the answer for this? Yes, most of you are right. Occipital cortex. The answer is occipital cortex. Yes, very good. Reza, Shahid, very good. The answer is occipital cortex. So the hint in the question is macular sparing. So let's see what is macular sparing. What is macula first of all? See, macula is the centermost part of your retina. So when it's the centermost part of the retina, when you look at the visual field, all objects that are in the center field will exactly fall on your macula. The objects in the center field will fall on the macula. So macula is responsible for center field vision. Objects in the center will fall on the macula. And the special property of macula is that right-sided macula will have a representation on right side visual cortex as well as left side visual cortex. It has bilateral wide representation. So even though your right-sided visual cortex is damaged, macula will not be affected. Why? Because it is represented on the left side also. It has a wide representation. It has bilateral representation. That is why whenever right-sided or left side, whatever it is, one side visual cortex is damaged, macula will always be spared. See, that's why look at this image here. This is how a macular defect patient will look at the world. See, he has homonymous hemianopia with macular sparing. Macular sparing means center field is spared. He is able to see what is in the center also. That is called macular sparing. Macular sparing means center field sparing. Clear? Yes. A 60-year-old patient complains of breathlessness on climbing stairs. On auscultation, heart sounds are normal and normal breath sounds are heard in bilateral lung fields. Flow volume loop is shown in color blue. Comment on diagnosis. Another very interesting question. So the question is about flow volume loop. So what is this flow volume loop? You have flow on y-axis in liters per second and volume in liters on x-axis. So how will you interpret this curve? So for interpretation of, yes, most of you have given the right answers. Very good. Gautami, Mugil, Chakri Kumar, Shahid, very good. Most of you are there with the right answers. So how will you interpret the curve? See, I'll teach you the easiest method to interpret the curve. So look at this. What you see in orange is a normal curve, and what is on pink is for restrictive disorders, and what is in green is for obstructive disorders. You know what are restrictive disorders? Restrictive disorders are like fibrosis, scoliosis, or obesity, where the patient has restriction in inflating the lungs, in expansion. So all restrictive disorders are disorders of inspiration. What are obstructive disorders? In obstructive disorders, there is some obstruction in your respiratory tract. You are not able to overcome the obstruction and breathe out. So it is a problem of breathing out. So all obstructive disorders are disorders of or difficulty in expiration. Okay, this is something general. So orange colored curve is normal, and you can see the pink colored curve which is shifted to right in restrictive disorders, and the green curve which is shifted to left in obstructive disorders. So the easiest way to analyze the curve is, as you know already, you have flow on y-axis and volume in the sense it is the volume of air that is inside your lungs. So volume on x-axis. Look at the normal curve. This is the total lung volume or the total lung capacity for the orange colored curve. And what is this small portion? This small portion is the volume of air which did not move out. It's still staying inside the lungs. So that is residual volume. And you have two loops here. The loop which is below the axis is inspiratory loop, and this is expiratory loop. Above the x-axis is the expiratory loop. So in a normal curve, look at the total lung capacity, total amount of air that is there in the lungs, this much. And look at the residual volume, what is residual volume? Even after you breathe out, some amount of air will always be present inside. That is called residual volume. So see what happens in restrictive disorders. In any restriction, the pink colored curve, the total lung capacity becomes like this. Total lung capacity decreases. See, when your total lung capacity itself decreases, residual volume will also decrease. Residual volume also decreases. So that is why the curve shifts to the right. Yes, there is a question. Dr. Priya, why in restrictive there is right side shift? It is right side shift because we are talking about on the x-axis, you are talking about the volume of air in the lungs. So during inspiration in restrictive disorders, you're not able to inspire that much of air. That is why the volume decreases and the curve shifts to the right. Okay. So what do you need to remember here is restrictive disorder R for right side shift, R for reduced volume, reduced residual volume, reduced total lung capacity. Okay, remember like this: restrictive disease, R for right side shift, R for reduced volumes. Just the opposite happens in obstructive diseases. Look at the green colored curve. In obstructive diseases, total lung capacity increases. When total lung capacity increases, see, during the next breath, what happens? You have an obstruction there. So you're not able to push out much of air. So lot of air remains inside as a residual volume. So residual volume also increases. So residual volume also increases. So this shifts the curve to the left. So obstructive diseases, left shift, increase in residual volume, increase in total lung capacity. So this is how you'll be able to interpret this curve. And now over to the question. So clearly they have shown a right shift of the curve. It's a restrictive lung disease. And one more point to be noted here is, in obstructive diseases, clearly you can find a scooping here. Okay, that is called as scooping of the curve. So that is because of when you're trying to overcome the obstruction and push out the air, you get that scooping of the curve. Okay, another typical finding for obstructive diseases. Yes, what is that? Ma'am, please take a class on CNS on YouTube. Okay, we'll do that, doctor. Next, for other sessions, we'll do that. We'll move on. Over to the question. Another very interesting clinical question. Rabies virus will use which kind of molecular motor to cause involvement of central nervous system from the site of inoculation into the host? Yes, I think most of you will be able to answer this right. Yes, the answer is dynein. So what is the question about? The question is about axonal transport. So what is axonal transport? Axonal transport means substances are moving along the axon both in forward and backward direction. Yes, very good. Very good, Shahid. Very good. Most of you are there with the right answer. Excellent. So there are two types of axonal transport. This is called anterograde transport. Anterograde transport. Anterograde means in the normal direction. Anterograde is otherwise called orthodromic. Orthodromic means whatever is synthesized in the cell body is transported into the through the axon to the axon terminal. This is normal direction. This is anterograde. So what is synthesized in the cell body? Your enzymes, neurotransmitters, proteins, all these are synthesized in the cell body and transmitted to the axon terminal in the normal anatomical direction. That is called anterograde transport. And for anterograde transport, you need a protein called kinesin. The protein is called kinesin. The other type of transport is called retrograde transport, which happens in the opposite direction. So retrograde means from the axon terminal to the cell body. Retrograde. So what are the substances which are transported in the retrograde fashion? What can you think of? See, just think of this. If a dog bites you here, the rabies virus will travel in from your hands in the opposite direction into the central nervous system. So that is going to go in the opposite direction. And if you have any injury or a wound, and when you come in contact with dirty sand that contains Clostridium tetani, tetanus toxin is again going to go in the opposite direction. So all viruses, especially rabies, tetanus toxin, all this travels in the opposite direction. This is called retrograde transport. So over to the question now. So the question is about rabies virus. So the answer is dynein. So to next question. In which of the following imbalances increased nerve excitability is seen? This is also a nice clinical oriented question. So to answer this question, so let me see who gets the right answer. Yes, what is the answer? Hypocalcemia. Very good. Hypocalcemia is the right answer. So what are the effect of ions on action potential curve? We have three important ions: sodium, potassium, and calcium. Any increase in sodium is called hypernatremia. Decrease in sodium is called hyponatremia. Hyperkalemia. Increase in potassium is called hyperkalemia. Decrease in potassium is called hypokalemia. Calcium. Increased in calcium is called hypercalcemia, and decrease in calcium is called hypocalcemia. So what is the effect of these changes in these ion concentrations on the action potential curve? So hope all of you know what is action potential and what are the phases of action potential. So we have depolarization phase and repolarization phase. What is depolarization? It is moving away from polarity. RMP is the polarized state. When it is moving away from polarity due to entry of sodium ions, see, sodium is a positive ion. So sodium entering inside or sodium influx causes accumulation of positive ions inside the cell, and that takes to the positivity. That is called depolarization. And what is repolarization? Movement of a positive ion outside the cell. That's why it is coming back to negativity in repolarization. It is returning back to polarity. That's why it's called repolarization. So that is potassium efflux. So now that you know sodium is responsible for depolarization phase, depolarization only determines the height of action potential. So sodium ions are capable of altering the height of action potential. So when you have hypernatremia, it will only increase the height of action potential. Hyponatremia, when you don't have enough sodium ions, it will decrease the height of action potential. Hyperkalemia. See, potassium and calcium have just the opposite effects. Okay, remember like this, potassium and calcium have opposite effects on action potential excitability, because hyperkalemia increases the excitability and hypocalcemia increases the excitability. That is why you have hypocalcemic tetany. It goes for increased excitation and in sustained contraction. And similarly, hypokalemia will decrease the excitability and hypercalcemia will increase the excitability. Okay, so just keep in mind potassium and calcium will have opposite effects. Increased potassium or decreased calcium will cause increased excitability. So over to the question. Which of the following imbalance will cause increased nerve excitability? Hypocalcemia. That's why you have hypocalcemic tetany. Yes, over to next question. The human lung never empties in spite of forceful expiration. This is due to lining of alveoli by surfactant. This surfactant is cleared by. Yes, what is the answer for this? This surfactant is cleared by. This is a fact question. GM-CSF. Surfactant is produced by type 2 pneumocytes. Surfactant is cleared by GM-CSF. What is GM-CSF? Granulocyte macrophage colony stimulating factor. So this is what clears the surfactant. After its job is done, GM-CSF clears the surfactant. If you have any problem with this GM-CSF, or if you have any defect in GM-CSF, there is nobody to clear the surfactant. Now what happens? Surfactant accumulates. Accumulation of surfactant is called alveolar proteinosis. Alveolar proteinosis. And when you have so much accumulation of surfactant, you have to treat the patient by giving a lung wash. That's called a whole lung lavage. Alveolar proteinosis is treated by whole lung lavage. Yes, we'll move on to the next question. A patient with HbA1c of 11.4% has come to your clinic with severe pain in feet at night. Which nerve fibers are involved in this patient? Okay, the question is about severe pain. So we need to know what are the nerve fibers which carry pain. So what are the nerve fibers which carry pain? Yes, what are the two types of nerve fibers that carry pain? Yes, A delta and C fibers. Both A delta and C fibers can carry pain, but the difference is that A fibers are large fibers, myelinated fibers, so they will conduct very fast. So A delta fibers will carry fast pain. C fibers are unmyelinated, slow fibers, so they will carry slow pain. Or I can say A delta carries first pain and C carries second pain. So when you say fast pain, first pain, all these are sharp pains. Example, a needle prick injury, electric shock, all these are sharp pain. And slow pain, example is dull pain. Dull pain, all your abdominal pains, renal colic, gastritis, okay, all kinds of abdominal pains are dull pains. So in this case, the patient has severe pain in the feet at night. So what is that pain fiber which is carrying it? So from the options given, we have only C fiber which carries pain. So the answer is C. Go to the next question. A 60-year-old known case of diabetes has been noticed on a laboratory workup to have microalbuminuria. What is the site of reabsorption of proteins in the ultrafiltrate? So the question is, ma'am, please explain the mnemonic. What is the mnemonic, doctor? For this one, huh? Oh, the mnemonic for nerve fibers. Yeah. We'll discuss that in nerve physiology. Ishwar, okay. So over to this question. What is the site of reabsorption of proteins? Keep in mind, proteins are 100% reabsorbed. Proteins are 100% reabsorbed. And where it is reabsorbed? Proximal convoluted tubule. Not only proteins, glucose is also 100% reabsorbed in the proximal convoluted tubule. See, proximal convoluted tubule plays a very important role because 100% glucose is reabsorbed, 100% proteins are, which means proteins and glucose don't cross the PCT and go to the next part of the tubule. They are fully reabsorbed in the PCT itself. And maximum reabsorption of salts and maximum reabsorption of water also takes place in the PCT only. You keep these points in mind. Yes, over to the next question. So we'll see 2020 December FMG pattern questions. Very easy question. Identify the movement taking place in the intestine. I'm sure all of you have done this. Peristalsis. So what is peristalsis? When you have a bolus of food, when you have the portion behind the bolus contracting and the portion in front relaxing, this is called peristalsis. So when food is pushed like this movement, it is called peristalsis. What is the other type of movement taking place in the intestine? Segmentation. What is segmentation? See, in peristalsis, you have contraction behind and relaxation in front. But in segmentation, you have contraction behind and contraction in front also. See, both the segments are contracted. Both front and back, you have contraction. So it becomes a small segment. So the whole intestine is divided into small segments. That is called segmentation. So what is the importance of peristalsis? Is to push the food. What is the importance of segmentation? Why is it forming small segments like this? It is giving more time for reabsorption of materials, for reabsorption of food, for absorption. It is giving you more time, forming small segments so that food stays there for a longer time, giving more time for reabsorption. That is the significance of segmentation. Which of the following hormone will regulate the release of prolactin from anterior pituitary? So the question is about release of prolactin. So we learn about prolactin and we'll come back to this. Yes, the answer is D. thyrotrophin releasing hormone. Very good. So what are the factors increasing prolactin secretion and what are the factors decreasing prolactin secretion? So how will you remember the factors which are increasing prolactin secretion? See, prolactin produces lactation or it increases the secretion of milk. So remember S for S factors. All S factors will increase prolactin secretion. Sucking of breast, stimulation of breast, stress, sex, sex hormones, strenuous exercise, sleep, surgery, and one other factor which does not start in S, one exception is thyrotrophin releasing hormone, TRH, which also increases prolactin secretion. So remember, S factors increase prolactin secretion. What are the factors which decrease prolactin secretion? Dopamine. Dopamine decreases prolactin secretion, and L-DOPA, which is a form of dopamine that also decreases prolactin secretion. Bromocriptine, which is a dopamine agonist that also decreases prolactin secretion. Somatostatin. Somatostatin decreases prolactin secretion. We learned somatostatin in detail later on, okay? Because somatostatin is a universal inhibitor which inhibits most of the hormones. Okay, we'll see what are they. Later on, we'll see when in endocrinology. So back to the question. Which will regulate the release of prolactin? Thyrotrophin releasing hormone. All S factors plus thyrotrophin releasing hormone. Brown-Sequard syndrome leads to damage too. So first of all, what is Brown-Sequard syndrome? See, Brown-Sequard syndrome means hemisection of the spinal cord. That is called Brown-Sequard syndrome. So look at this. When one half of the spinal cord is cut, it is called hemisection of the spinal cord and it results in Brown-Sequard syndrome. So what are the clinical features of Brown-Sequard syndrome? So how can you easily study this? See, we have ascending sensory tracts and descending motor tracts. First thing that you should keep in mind is all ascending tracts are sensory tracts because all sensations, they are carried from the periphery. Touch, pain, pressure, all this is carried from the periphery into the center. So they will ascend like this. So all ascending tracts are sensory tracts. And all descending tracts are motor tracts. Because the motor impulse or the impulse for the movement comes from your motor cortex, from there to spinal cord, from spinal cord to your muscles. So all descending tracts are motor tracts. So now let's see what are the tracts which go through this part of the spinal cord which is damaged. So let's trace the ascending tracts. What are the two ascending tracts? Dorsal column, spinothalamic tract. These are the two ascending tracts. So first let's see, this is left side and this is right side. So this is maybe your left leg or hand or whatever it is. So from here, dorsal column carrying the sensation goes to the spinal cord. Dorsal column does not cross at the level of spinal cord. If you have studied tracts, you will know this. Dorsal column crosses to the opposite side at the level of medulla. So it goes up to medulla and crosses at the level of medulla and goes to the opposite side, sensory cortex. This is dorsal column. So you find that on the left side, dorsal column is affected. Now let's trace the spinothalamic tract on the left side. In purple, let me do that. This goes to the spinal cord. Spinothalamic tract. Where does it cross? It crosses at the level of spinal cord itself. So it crosses to the opposite side and goes like this. Is it affected? No, this is not affected. It does not go through the affected part of the or the hemisected part of the spinal cord. So on the same side of lesion, only dorsal column is affected. Spinothalamic tract is spared. Now let's trace the spinothalamic tract of the opposite side. So from the opposite side, you have spinothalamic tract. It goes to the spinal cord. Where does spinothalamic tract cross? Spinal cord itself. It crosses, goes to the opposite side, sensory cortex. Now is it going through the cut section of the spinal cord? Yes. So on the opposite side, spinothalamic tract is cut. And what does spinothalamic tract carry? Pain and temperature. So the pain and temperature fibers from the opposite side of the body are affected. So these are the two sensory tracts. What about the motor tract? The one motor tract which starts in the opposite side, and these fibers, 90% of the fibers cross to the opposite side. Be clear in this, 90% of the motor fibers which are descending down cross at the level of medulla. After crossing, they form the left lateral corticospinal tract. Left lateral corticospinal tract, which is passing through the cut section of the spinal cord. So which only after crossing it is called left lateral corticospinal tract. So which corticospinal tract is affected? Left side lateral corticospinal tract is affected. So the three findings are: on the left side or on the same side, dorsal column is affected, corticospinal tract is affected. On the opposite side, spinothalamic tract carrying pain and temperature is affected. Okay, repeatedly questions are asked from these three concepts only. Okay, don't confuse corticospinal tract. Only after crossing, 90% of the fibers after crossing, it forms lateral corticospinal tract of the left side. Okay, yes. So what is the answer for this question? A. Ascending sensory and descending motor pathways in the spinal cord. See, always it may not be so easy like this. They'll confuse you with dorsal column sensations or spinothalamic tract sensations. They'll give you pain and temperature on the same side, pain and temperature on opposite side, fine touch on same side, fine touch on opposite side. So you should know what are the sensations carried by the respective tracts. Okay. Yes, we'll move on to the next question. Sodium potassium chloride transporter. Sodium potassium chloride transporter for ultrafiltrate in tubules is located in. What does this strike you? Sodium potassium chloride NKCC. So where is NKCC located? On the loop, especially on the thick ascending limb. So we learned this in detail in renal physiology. So NKCC is the single most important channel which is present in the thick ascending limb. And what are NKCC blockers? What are the drugs which block NKCC? Excellent, Shahid. Loop diuretics. It's called loop diuretics. Your furosemide, etc. So the answer is thick ascending limb. Inhibition of sodium potassium ion channel results in which of the following? Sodium potassium channel means you're talking about sodium potassium ATPase. Every cell in the body has sodium potassium ATPase. Sodium potassium ATPase. What is the function of sodium potassium ATPase? To send out 3 sodium in exchange for 2 potassium. So basically the function is extrusion of sodium. So when you inhibit this channel, when this is inhibited, extrusion of sodium is affected. So sodium slowly begins to accumulate inside the cell. When sodium, which is a positive ion, is inside the cell, what will it do? It will cause depolarization. It will take it to more of positivity. Depolarization. Yes, so that's why the answer is depolarization, because sodium is a positive ion and it's taking it to positivity. Over to the next question. From the given pressure volume graph, Identify B accordingly. So this is a very interesting question. We'll learn about the curve and we'll move on to this question. So the curve is about the cardiac cycle diagram in the form of a loop. So it's very important that you know to analyze the curve. So look at the curve. So what is this? 50 ml on the x-axis, end systolic volume. What is end systolic volume? So this is your heart. When your heart is pumping, after it has pumped blood into the aorta, 50 ml is remaining. So that is end systolic volume, ESV. And now heart is going to get filled. So it is filling now. So when heart is getting filled, it is filled up to 130 ml. So what is 130 ml called as? End diastolic volume. At the end of diastole, 130 ml is there. So 130 ml is called end diastolic volume. So this phase is called from D to A. The phase is called ventricular filling phase. So after the ventricles have filled, the mitral valve's job is over because mitral valve has opened and blood has flowed into the ventricles. Its job is over. So at point A, which valve will close? Mitral valve closes. So at point A, mitral valve closes. Now which valve should open? The mitral valve has closed and you have aorta. You have aortic valve here. Ventricle is full now. Now which valve should open? Aortic valve should open and blood will be pushed into the aorta. So at point B, aortic valve opens. But there is a small interval where mitral valve has closed, aortic valve has not yet opened. See, look at this one. Mitral valve has closed, aortic valve has not yet opened. So small point where both the valves are closed. So when both the valves are closed, will the volume in the ventricle change? No. That's why it is called isovolumetric contraction phase. So an isovolumetric contraction phase, see, the volume remains at 130, isovolumetric, it doesn't change, but pressure increases because heart is contracting. So the pressure rises. That is called isovolumetric contraction phase. Yes. Now aortic valve has opened. When aortic valve opens, let's open the aortic valve. Aortic valve opens and it pumps blood into the aorta. So now what is this called? Ejection of blood. So B to C is called ejection phase. Okay, the ventricle is ejecting blood into the aorta. So after it has ejected blood, see during ejection phase, look at the volume. It's coming from 130 to 50 again. 130 was filled in, it's ejecting and it has ejected some amount of blood. So that 50 ml of blood is still remaining there. So how much has it ejected? End diastolic volume 150. End systole 50 is remaining. So how much has been pushed out? 130 minus 50, which is called stroke volume, which will come up to 80 ml, 70 to 80 ml. So what is stroke volume? For every stroke of the heart, how much volume of blood has been pushed out? 80 ml. Or you can say according to formula, end diastolic volume minus end systolic volume. And at point C, what happens? Aortic valve closes. Aortic valve closes. Now which valve should open? Mitral valve should open. So at D, mitral valve opens. But note that there is a small gap where aortic valve has closed, mitral valve has not yet opened. So small point where both the valves are closed. So will the volume change? No. That's why it is called again an isovolumetric phase. Isovolumetric. But look at the pressure. It is decreasing. It shows you that it has started to relax. So it is isovolumetric relaxation phase. So this diagram is very, very, very important both in physiology and in medicine. So they can ask you valvular events or they can ask you calculations based on end diastolic volume, end systolic volume and stroke volume. So learn this diagram carefully. So now back to the question. From the given pressure volume graph, what is B? Opening of aortic valve. So at the end of isovolumetric contraction, you have opening of aortic valve. Which part of the nephron does maximum water reabsorption take place? See, I already told you this. PCT is very important because maximum salt reabsorption, maximum water reabsorption, around 60 to 70% of salt as well as water, or you can say maximum salt and maximum water reabsorption takes place in the PCT. The answer is A, PCT. Yes, with that we complete December questions. Yes, very good. All of you, very good for the right answers. Ramya, Smiley, very good. So we'll move on to system-wise important point discussions. So general physiology. Which of these is true about SGLT1? See, repeatedly questions are asked from certain topics. So I have chosen those repeat topics, and I thought I'll discuss only those repeat topics because it will be of help for you when you go for your exams, like just like a revision of repeated topics. So starting with general physiology, most important topic here is cell membrane transport. Repeatedly questions are asked from cell membrane transport. So what is the cell membrane transport mechanism? See, look at this diagram. Very beautiful diagrams that I got from Google. So with this, let's learn cell membrane transport mechanisms. There are two types of transport mechanisms: active transport and passive transport. So what is active transport? So look at this man who's climbing there. See how hard he is trying to climb the mountain. He is going against the mountain, against the height of the mountain. So that is going against the concentration gradient. So in active transport, it is going against concentration gradient. See, when you're going against the height like this, definitely you need energy. So definitely you need energy for this. There are two types of active transport: primary active transport and secondary active transport. See, primary active transport is, look at that man, he's climbing there. He is using his own energy to climb up the mountain. He is using his own sodium potassium ATPase to climb up the mountain. That is called primary active transport. What is the primary energy? His own energy. So that is sodium, potassium, ATPase, or any kind of ATPase. So all kind of ATPases will fall under primary active transport. Then what is secondary active transport? Secondary active transport is if your friend is climbing the mountain and you climb on top of him like this. You catch hold of him and you're trying to use his energy and you're climbing up the mountain. Same only, you are going against the concentration gradient, you're using energy, but you're not using your energy, you're using your friend's energy. Indirectly, you're using energy. Who's the friend? Almost always the friend is sodium. So any kind of NKCC, sodium, potassium, chloride transporter, or so just sodium chloride transporter, or SGLT. What is SGLT? Sodium glucose co-transporter. See, SGLT is of two types. There are very many types. We are concerned about SGLT1 and SGLT2 because SGLT1 is present in the intestines. SGLT2 is present in the kidneys, especially your PCT. And in secondary active transport, there are two types. Both the substances can move in same direction. That is called symport. If both substances move in same direction, that is called symport or co-transporter. Co-transport. If both the substances move in opposite directions, that is called antiport or counter-transport. Example for counter-transport is sodium hydrogen exchanger. In your heart, you have sodium hydrogen exchanger. And one more point about sodium potassium ATPase is there is one hormone which increases the levels of sodium potassium ATPase or increases the activity of sodium potassium ATPase, insulin. It has a clinical importance because if insulin increases sodium potassium ATPase, what is the function of sodium potassium ATPase? To send out sodium and to take in potassium. If insulin, imagine you're treating a DK, a diabetic ketoacidosis patient who has 300, 400 levels of glucose, you're infusing him with insulin. When you give insulin, insulin increases sodium potassium ATPase activity, so it will push all sodium or all sodium out and potassium inside. And most evidently you will see hypokalemia because potassium is being pushed inside. It results in hypokalemia. That is why in DKA patients and ICU setups, if you see, when they treat patients with insulin, nearby the patient you will see potassium syrups because insulin can cause hypokalemia. It will decrease potassium levels. That's why you give potassium syrup. Yes, over to passive transport. So in passive transport, there are different types of passive transport. So one is, see, passive itself means you're not using any energy because, see, look at that boy who is just rolling down the mountain. See, no energy. Freely you can come down. So it is along the concentration gradient. That is why you don't need any energy. No energy is needed. So in passive transport, you have different types. Simple diffusion. See, simple diffusion is what is happening to that boy there. Simply, if you stand on top and you roll down, if you lie down there, you can just roll and you can fall down. No energy. Simply, you're coming down. This is done by oxygen and CO2. See, look at that boy, what he's doing, no energy. Oxygen and carbon dioxide gases take up this simple diffusion method because if these gases are going to depend on any transporter or anything, it is very dangerous because you need to breathe without stopping. So oxygen and carbon dioxide should be able to diffuse simply. Only then we can survive. The next type of transport is facilitated diffusion. So in facilitated diffusion, you need a facilitator. So what is this facilitator? The facilitator is a, just imagine there's a bus here and this bus is going to carry you down. Okay. A bus is like a carrier protein. It's carrying you down. So for facilitated diffusion, you need a bus or you need a carrier protein. You need a carrier protein. And if the bus service is stopped on top, you cannot come down. So there is a level of saturation here, and the bus can accommodate only so many number of people. It can maximally transport only so many number of people. So you have a T max, transport maximum, and saturation. It can get saturated. So facilitated diffusion, you need a carrier protein. Most of the time it is GLUT, glucose transporter. GLUT, it has a Tmax, it can get saturated. But simple diffusion, no Tmax, no saturation. And another type of passive transport is transport of water by osmosis. Osmosis. Water can simply move or it can take aquaporins, which are water channels to move. So this is about passive transport. Yes, thank you, Dr. Alvin. So with this, we'll move on to the question. So look at this question now. Which of these is true about SGLT1? So SGLT is a secondary active transporter which is present in the intestine. SGLT2 is present in the kidneys. Another type of transport called vesicular transport. So what is vesicular transport? It is a special type of active transport by using vesicles. That's why it's called vesicular transport. See this one in the first diagram, you can see that something is moving out. It is called exocytosis. And for exocytosis, you need calcium, you need snare proteins by which vesicles move the substances out. And the other type is called endocytosis. Endocytosis. So what is endocytosis? Taking in something with the help of vesicle is endocytosis. Endocytosis is of different types. Pinocytosis. Pinocytosis means liquid particles are taken in by pinocytosis. It's called cell drinking. Phagocytosis. Phagocytosis is cell eating. Solid particles are engulfed by phagocytosis. Receptor mediated endocytosis. Receptor mediated endocytosis. So in receptor mediated endocytosis, you need certain proteins called clathrin. See, I love these names. Nice to pronounce, no? Clathrin, caveolin, megalin, cubulin. So these are all proteins which are involved in receptor mediated endocytosis. And megalin especially, it has a clinical importance because endocytosis of insulin is because of megalin, and any problem with this megalin can result in Donnai-Barrow syndrome. Donnai-Barrow syndrome. And cubulin, this is important for endocytosis of B12. Therefore, it is associated with megaloblastic anemia. B12 deficiency, which causes pernicious anemia or megaloblastic anemia. So this is about vesicular transport. Next question. All are second messengers except another repeatedly asked topic is about second messenger systems. So the answer for this is yes, we'll discuss and we'll move on to the answer. Let's learn about G protein coupled receptors. Very, very important topic. What is this G protein coupled receptor? See, any hormone, when it binds to its receptor and it activates G protein coupled receptors, there are hormones which act through G protein coupled receptors, or majority of the hormones act through G protein coupled receptors. There are different second messengers which are activated when G protein coupled receptors are activated. So we'll see the sequence of events. So whenever a hormone binds to the receptor and G protein coupled receptors are activated, the structure of G protein coupled receptor is 1, 2, 3, 4, 5, 6, 7. It spans the membrane 7 times. That's why it is called 7 helix receptor. And it looks like a snake, no? So it's called serpentine receptor. Serpentine receptor. So whenever this G protein coupled receptors are activated, it has alpha, beta, and gamma subunits. Mostly it is the alpha subunit which is getting activated. This will activate the second messenger systems. So what are the second messenger systems? See, it can take either of these pathways. Number one, it can activate adenylyl cyclase. When adenylyl cyclase is activated, it will produce cyclic AMP. And when cyclic AMP is produced, it will activate protein kinase A. See, A for adenylyl cyclase, A for cyclic AMP, A for protein kinase A. And protein kinase A will exert its actions. And number two, it can activate guanylyl cyclase. And when guanylyl cyclase is activated, it produces cyclic GMP. This will activate protein kinase G. See, guanylyl cyclase, cyclic GMP, protein kinase G. And the next pathway is phospholipase C. When phospholipase C is activated, PIP2 is converted into IP3 and DAG. IP3 is inositol triphosphate, DAG is diacylglycerol. And IP3 will in turn activate calcium, and DAG acts through protein kinase C. See, phospholipase C, protein kinase C. So of all these, cyclic AMP, cyclic GMP, IP3, calcium and DAG are called as second messengers. Okay, these five are important second messenger systems, and you have hormones which act through cyclic AMP, a list of hormones which act through cyclic GMP, similarly those which require calcium and those which require DAG. So what are the five second messenger systems? Cyclic AMP, cyclic GMP, IP3, DAG and calcium. So all are second messengers except guanylyl cyclase. Guanylyl cyclase is not a second messenger system. Okay, it is just a precursor. Yes, we'll move on to nerve physiology. There are different types of nerves, neurons, unipolar cells, which are seen in invertebrates, and also in human embryos you can see unipolar cells. Bipolar, see what is unipolar? From the cell body, if only one process arises, see, from cell body there's only one process arising, that is unipolar. From the cell body, if you have one and two process arising, that is bipolar. It is seen in bipolar cells of retina. And from the cell body, it may look like as though one process is arising, but it eventually divides into two processes. That is called pseudo-unipolar, seen in dorsal root ganglion cells. And multipolar cells. Multipolar means from cell body, multiple processes come out. So the one long process is axon, the others are all dendrites. So this is called multipolar. So these are the different types of neurons. An example of multipolar cells is motor neuron of the spinal cord, pyramidal cells of hippocampus, and Purkinje cell of cerebellum. And a recently asked question was an image-based question about the cerebellar cell, Purkinje cell. So identify the cell type of cerebellum shown in the image. So how will you identify the cell? So a typical Purkinje cell has a diffuse network. Dendrites divide into a diffuse network of dendritic spines. So this is called the Purkinje cell of cerebellum. This was the exact question that was asked. Purkinje cell of cerebellum. How do you identify? There's a diffuse network of dendritic spines. So this is about the different types of neurons. So let's move on to the types of nerve fibers. The types of nerve fibers, there are basically three types of nerve fibers: A, B and C. And in A you have A alpha, A beta, A gamma and A delta. And then we have B fibers and C fibers. See, this table is very important, and remembering the functions of these types of nerve fibers is also very important. So an easy method to learn this is, yes, I teach my students a small story to remember this. So if you want to buy a car, you go to the motor company and meet the proprietor. So motor company, proprietor for proprioception. And he takes you to the car. What will you try to do? You will try to touch the car and you will try to press the car and see. Then what you will ask him, shall I go inside the car? So intrafusal muscle fiber. And once you are inside the car, you switch on the AC, it's very cold. So cold, and you ask the cost of the car, he tells you the price of the car. It's so costly that you get a headache, pain. Then what you decide? Car venda, you call an auto, let me go home. So you call for an auto. And C fibers, when you are inside the auto, now you realize that no AC, you're feeling very hot. But if it rains, it can be cold inside the auto also. That is also painful, dull pain. Okay, somehow make some story or mnemonic or whatever it is and try to remember this. See, another small trick in learning for entrance exams is whenever you find something difficult, correlate it to something which you like. Okay, if you're learning something which you don't like, correlate to a story or correlate with somebody whom you like very much, or make it up as a story or something. Definitely you'll never ever forget that. Okay. So A alpha fibers, motor and proprioception. Function of A beta is touch and pressure. Function of A delta is it carries cold and pain. And function of B fiber is autonomic nerves. Function of C fiber, autonomic nerves. So the difference between autonomic nerves of B and C is B comes first, so it carries preganglionic autonomic fibers. Preganglionic. C comes next, so it carries postganglionic. And the difference between the pain we already saw, A delta carries sharp pain and C carries dull pain. And the other points to remember here, A fibers are, will give all credits to A. Okay, A fibers are largest, fastest. Why fastest? Because they are myelinated. Poor C fiber, smallest, slowest. Why slowest? Because it is unmyelinated. And B will share both the properties. Okay, so this is how we complete types of nerve fibers. So the next topic on action potential. So some fill in the blanks for you to fill up. Yes, so try filling in this. Resting membrane potential is due to dash ion. Yes, maybe we'll complete action potential and we'll come back to this to the fill in the blanks. So in action potential curve, we already saw depolarization, repolarization. Before that, you have RMP. RMP means resting membrane potential, and RMP is because of potassium ions. Potassium ions are responsible for RMP. Local potential, opening up of few sodium channels. See, when you have one or two sodium channels opening, few sodium ions come inside. Sodium ions are positive ions. When you have few sodium ions coming inside, it will increase the positivity a little bit. So that little increase in positivity is local potential. Once local potential reaches the threshold, you have rapid movement of sodium ions inside, that is called sodium influx, and it goes to positivity, depolarization. And once when it reaches plus 35 or something, after that potassium ions are pushed out. Potassium is a positive ion. Positive ion moving outside will cause repolarization, so it returns back to polarity. And when it's returning back to polarity, it does not exactly stop at RMP. It goes beyond RMP and it's coming back to polarity. That is because these potassium channels are very lazy channels, slow, leaky potassium channels. So what they do, one by one, they'll be leaking. So that's why it goes even beyond RMP, hyperpolarization, because of slow, leaky or lazy potassium channels which keep leaking potassium ions, and then it will come back to polarity. So this is about action potential curve. And in action potential curve, we have two refractory periods: relative refractory period and absolute refractory period. So what is this refractory period? See, refractory means what? Not responding. Refractory means not responding. During absolute refractory period, so during the period that I'm going to shade in yellow now, during this period, the cell is absolutely refractive. How much ever stronger stimulus you give, you cannot elicit a second action potential. Keep this point in mind. You cannot elicit a second action potential because the cell is absolutely refractive. But during this phase, which I am going to shade in blue now, the cell is in relatively refractory period. Relatively refractory period means it is only relatively not responding. So if you try to give a second strong stimulus, so if I'm trying to give a second strong stimulus at this point, I can elicit a second action potential from that point itself. So that is called relatively refractive. Don't confuse this with all or none law. What is all or none law? It speaks about the height of action potential. However stronger stimulus you give, you can never increase the height of action potential. That is all or none law. But in refractory period, we are talking about not about the height of action potential. We are talking about getting a quicker second action potential, a second action potential. Okay. So in absolute refractory period, however strongly you stimulate, you cannot elicit another action potential like this. It cannot happen. But in relative refractory period, you can elicit a second action potential. But all or none law speaks about if you increase the strength of the stimulus, you can never alter the height of action potential. It will remain the same. That is called all or none law. Okay, don't confuse both. Back to this now. Yes, what is the answer for this now? Resting membrane potential is due to potassium ions. Depolarization is due to sodium influx. Repolarization is due to potassium efflux. Hyperpolarization is due to slow leaky potassium channels. Slow leaky potassium channels. Yes, with this we complete action potential. Let's move on to the next topic. Another important repeatedly asked topic, strength duration curve. So what are we trying to learn from the strength duration curve? When you stimulate a nerve which supplies a muscle, if you give a particular strength of stimulus and you're stimulating it, the muscle will respond by contracting. So that's that when you plot it on a curve, it gives you the strength duration curve. So look at this, strength on y-axis and the time or duration for which you are giving on x-axis. So when you stimulate the muscle with different stimuli, with different strength of stimuli, the minimum stimuli that can produce a response, that is called as rheobase. The minimum stimuli, the minimum strength of stimulus which can produce a response. So what is rheobase? See, look at this, the minimum strength of stimulus that is producing a response. So this is the response curve. So rheobase means the minimum strength of stimulus that can produce a response. For how much duration you should give this rheobase? For utilization time duration, you have to give this rheobase. So what is utilization time? The time for which rheobase should be given. So the minimum strength of stimulus which can elicit a response is rheobase. Time for which you give the rheobase is utilization time. So that, see, utilization time is time for which you give one rheobase. The time for which you give twice the rheobase is 𝗏𝗃𝗃. So 𝗏𝗃𝗃 is the time for which you give twice the rheobase. That is called 𝗏𝗃𝗃. So time for which you give one rheobase is utilization time. Time for which you give twice the rheobase is 𝗏𝗃𝗃. So all this is only asked from this curve. Nothing much more has been asked. Yes, we'll move on to the next topic, synapse. Synapse is also a very important topic. So what is a synapse? The junction between two nerves is called as a synapse. So you have the gap is called as the synapse. So you have a presynaptic neuron and a postsynaptic neuron. And in between both, the space is called as the synaptic cleft. So what is the function of the presynaptic terminal? It has vesicles which release neurotransmitters. Neurotransmitters are released into the synaptic cleft, and these neurotransmitters attach to the receptors which are present on the postsynaptic terminal. Basically, there are two types of synapse: chemical synapse and electrical synapse. Chemical synapse means by using chemicals, which are nothing but your neurotransmitters. So a chemical synapse will release neurotransmitters. See, when a chemical synapse is releasing neurotransmitter, it will take extra time for this. So that causes the synaptic delay, 0.5 millisecond of synaptic delay. It is the time taken for it to release a neurotransmitter. But electrical synapse, the cells are coupled electrically. So an electrical synapse is formed by gap junctions. They are very faster. There's no synaptic delay. And once when the impulse reaches the postsynaptic membrane, it can respond, the postsynaptic membrane, it responds either by producing excitatory postsynaptic potential or inhibitory postsynaptic potential. The postsynaptic neuron, either it can get excited or it can get inhibited. What is that based on? That is based on the neurotransmitter which is produced. So if the neurotransmitter is an excitatory neurotransmitter like glutamate, it will produce excitatory postsynaptic potential. If the neurotransmitter is inhibitory like GABA or glycine, it will produce inhibitory postsynaptic potential. And what is the mechanism of this ion mechanism of these excitatory and inhibitory? In excitatory postsynaptic potential, you have either sodium influx, sodium coming inside, or calcium influx. But in inhibitory postsynaptic potential, you have chloride coming inside, because chloride is a negative ion. If it comes inside, negative ion coming inside will inhibit. So chloride influx is the mechanism for inhibitory postsynaptic potential, or K plus efflux. K plus is positive, potassium is a positive ion. If it is moving out also, negativity will increase inside the cell and it can cause inhibition. So chloride influx or potassium efflux, both can cause inhibitory postsynaptic potential. Again, a repeatedly asked concept. Yes, we'll move on to muscle physiology. A recently asked AIMS question. Following is an electron micrograph of human skeletal muscle. The portion marked is, very nice question. So this is an electron micrograph diagram. So you should know the different bands that are present inside the skeletal muscle myofibrils. Only then you will be able to answer this question. So we'll discuss about the muscle in detail and we'll come back to the question. First of all, what is the innervation to a muscle? So from the spinal cord, this is your spinal cord, you have innervation into the muscle. This is the muscle. The muscle is made up of extrafusal muscle fibers. So these are the extrafusal muscle fibers. And muscle has structures called muscle spindle. So the yellow one is muscle spindle. The fibers inside the muscle spindle are called intrafusal muscle fibers. So you have two types of fibers. Fibers present outside the muscle spindle, extrafusal muscle fibers, and these are called intrafusal muscle fibers. And from the spinal cord, you have two types of neurons which are innervating, two types of nerve fibers which are innervating this muscle now. A alpha, which innervates the extrafusal muscle fiber, and A gamma, which innervates the intrafusal muscle fiber. Okay, a repeatedly asked concept. From spinal cord, you have A alpha, which innervates the extrafusal muscle fiber, A gamma, which innervates the intrafusal muscle fiber. So now you should understand that both the extrafusal muscle fiber and the intrafusal muscle fiber should contract together. Only then you will have a smooth muscle contraction. So A alpha and A gamma are activated together. That is called alpha gamma coactivation. So first let's see what is the role of A alpha. What is this A alpha doing for the muscle to contract? See, first of all, the point where this A alpha meets the extrafusal muscle fiber, this junction is called as neuromuscular junction. So let's learn about the neuromuscular junction. Then we'll move on to A gamma. So first we are learning what is A alpha doing for the muscle contraction. A alpha meets the extrafusal muscle fiber at the neuromuscular junction. Let's zoom into the neuromuscular junction. So look at this neuromuscular junction now. So just follow this. So we have a lower motor neuron. So this is A alpha motor neuron. Okay, A alpha lower motor neuron. And this is the muscle. The place or the junction between A alpha and the muscle. Look at this diagram. What is it called? The junction between A alpha and the extrafusal muscle fiber, neuromuscular junction. So the yellow space is the neuromuscular junction. Neuromuscular junction. So follow the events. So what is the first step that happens? So when you have corticospinal tracts descending down into the spinal cord, they will trigger A alpha and A gamma. When A alpha is activated, first step that happens is opening of voltage gated sodium channels in the A alpha motor neuron. So when A alpha motor neuron is activated, it will activate voltage gated sodium channels. When voltage gated sodium channels are activated, it will produce action potential. So you have action potential. This action potential travels along the neuron and it comes like this. When it reaches the axon terminal, so this is the axon terminal. In the axon terminal, you have voltage gated calcium channels. When action potential reaches, these calcium channels will open and calcium will enter inside. This is calcium entry. This calcium, see, wherever you have calcium, it will cause a movement. It is going to cause movement of vesicles containing acetylcholine. So these vesicles will move. They'll move to the synaptic cleft. They'll open up and they'll release acetylcholine. So acetylcholine is released. This acetylcholine now binds to, it will cross the synapse. It will reach the muscle and it will bind to nicotinic receptors which are present on the muscle. And what happens inside the muscle? The same sequence of event only happens. What is the same sequence? Opening of voltage gated sodium channel, development of action potential. Now in the muscle, action potential is developed. It moves inside. And when action potential moves inside, it will cause the release of calcium. So in the muscle, the store of calcium is called as SR, sarcoplasmic reticulum. See, for the neuron, calcium came from outside. But for muscle, the calcium store of muscle is called as sarcoplasmic reticulum. SR releases the calcium. And for SR to release the calcium, you need two receptors, dihydropyridine, DHP. DHP is dihydropyridine receptor and RYR is ryanodine receptor. So when you have calcium, so I told you whenever there is calcium, you will have a movement. So what is the movement? Movement of actin over myosin. So movement of actin myosin. Therefore, muscle contracts. So this is the mechanism of muscle contraction. And now let's see the clinical importance of all this. So let's start with voltage gated sodium channel. Tetrodotoxin. What is tetrodotoxin? Tetrodotoxin is a poison which is present in puffer fish. It is a voltage gated sodium channel blocker. It can cause respiratory paralysis and death. If you don't cook the fish properly, it can cause respiratory paralysis and death. Lambert-Eaton syndrome. So what is Lambert-Eaton syndrome? Autoantibodies against voltage gated calcium channel is called as Lambert-Eaton syndrome. And in Lambert-Eaton syndrome also, it can cause muscle paralysis. And if it affects the respiratory muscles, it can cause death. Clostridium botulinum. There are different types of Clostridium botulinum. See, before that, for the vesicles to move and release acetylcholine, you need certain proteins called snare proteins. So these are the snare proteins. Synaptotagmin, synaptobrevin, syntaxin, and SNAP25. Clostridium botulinum blocks these snare proteins, and especially Clostridium botulinum type B blocks brevin. Clostridium botulinum type C blocks syntaxin, and Clostridium botulinum type A and E blocks SNAP25. So by blocking these snare proteins, it is blocking the release of acetylcholine. If acetylcholine is not released, no contraction, muscle goes for flaccidity. So that is called flaccid paralysis. That is why Clostridium botulinum causes flaccid paralysis. What about Clostridium tetani? See, Clostridium tetani is a poison which has a tendency to cause spastic paralysis. Why Clostridium tetani causes spastic paralysis? Because Clostridium tetani blocks GABA and glycine. It blocks GABA and glycine. What are GABA and glycine? GABA and glycine are inhibitory neurotransmitters. So when Clostridium tetani blocks GABA and glycine, there is no inhibition on the muscle. So the muscle goes for sustained contracted state, spastic paralysis. Especially when it affects the muscles of the jaw, it can cause locked jaw. What about acetylcholine esterase? See, acetylcholine esterase is an enzyme which degrades this acetylcholine. See, once when acetylcholine's action is over, all this acetylcholine is degraded by acetylcholine esterase. And you have drugs which inhibit this acetylcholine esterase. They are called acetylcholine esterase inhibitors. So what do acetylcholine esterase inhibitors do? They will inhibit acetylcholine esterase. So now there is nobody to degrade the acetylcholine. So acetylcholine level increases. It increases acetylcholine. What are the drugs? Edrophonium, physostigmine, and neostigmine. And what is that poison which blocks this acetylcholine esterase? OPC, or organophosphorus poisoning. It is present in insecticides and pesticides. So when OPC blocks acetylcholine esterase, now also there is nobody to degrade this acetylcholine. So acetylcholine level increases. Acetylcholine is a parasympathetic neurotransmitter. So it increases parasympathetic activity. What is the function of parasympathetic activity? It will increase all secretions. It will cause pinpoint pupil. It will cause all secretory activity. Your tears, your saliva. So all secretions increase. See, that is why if you have noticed on the rural side, when they bring suicide cases with insecticide poisoning or pesticide poisoning, patients will have frothing. They'll bring you the patient with frothing only. With that itself, you can identify that the poison is OPC poisoning because it increases parasympathetic activity, causing frothing and increased secretions. And what about myasthenia gravis? What is myasthenia gravis? Autoantibodies against nicotinic receptor. Okay, destruction of nicotinic receptor on the muscle is called myasthenia gravis. So it will cause muscle weakness. And how can you treat this myasthenia gravis? Say in myasthenia gravis, you have problem with nicotinic receptors. So few acetylcholine is there which is trying to act on the nicotinic receptors which are not affected. If you can give an acetylcholine esterase inhibitor to a myasthenia gravis patient, it will try to block the degradation of acetylcholine, because already myasthenia gravis patient has only little acetylcholine which is acting on the little bit of receptors there. That is going to be degraded. It's more dangerous for the patient. So you prevent the degradation of acetylcholine because already he has only few receptors. How will you prevent the degradation? Give him acetylcholine esterase inhibitor, edrophonium, physostigmine, neostigmine, for treating myasthenia gravis. And what about skeletal muscle relaxants? So you have two types of skeletal muscle relaxants: non-depolarizing muscle relaxant and depolarizing muscle relaxant. See, simple from the, take it from the terminology itself. Non-depolarizing means it will block the binding of acetylcholine to the receptor and it will block depolarization. It will not cause depolarization. That is non-depolarizing. Tubercularine and pancuronium. Depolarizing muscle relaxant means instead of acetylcholine, it will act as an agonist to the acetylcholine receptor and it will keep on causing depolarization and ultimately result in flaccid paralysis. Example, succinylcholine. And what about DHP and ryanodine receptors clinical importance? Dihydropyridine and ryanodine receptor. So these receptors are important for calcium release from SR. So if you have any problem with these receptors, dihydropyridine, mutation of dihydropyridine or ryanodine receptor, it's mostly a gain of function mutation. So the activity of dihydropyridine and ryanodine receptor increases. So there is more release of calcium, more muscle contraction. When the muscle contracts more, it will produce more heat. That is called malignant hyperthermia. And how can you treat malignant hyperthermia? Problem is with ryanodine receptor. So block ryanodine receptor. Ryanodine receptor blockers. Dantrolene sodium. Yes, this completes the entire neuromuscular junction and its clinical importance. So let's have a look at actin and myosin filaments also. So look at this diagram. You have actin, which is the thin filament, myosin, thick filament, and actin and myosin are attached to the Z lines. And the gap between two Z lines is called as a sarcomere. So this entire thing is a sarcomere. And actin and myosin are attached to Z line by elastin. So this and this is elastic protein called titin. So titin only attaches actin and myosin to Z lines. And when you look in the electron micrograph diagram, electron microscopy, myosin will appear as dark band because it is a thick one. So the bottom panel is the electron microscopy. So look at that. The entire myosin will look dark, and that is called A band. So the entire myosin is called A band. And you see that myosin and actin are arranged in stacks like this. So in the center of myosin, you have a small portion where there is no overlap of actin. This part where there is no overlap of actin. So in an electron microscope, that will look little lighter because there is no overlap of actin. So this is called a little lighter band, H zone or H band. So in the center of A band, you have H band. A band is the dark band, H band is the lighter band. And actin, the area where you have actin alone. So this portion where you have only actin, which is attached to the Z line, that will appear the lightest. Why? Because actin is the thin filament. So it will appear lightest. That is called I band. So on an electron microscopy, when you see dark band, that is A band. In the center of dark band, you have H zone. When you see a very light band attached to the Z line, that is I band. And one more point to be noted here is a repeatedly asked concept is what are the changes between relaxed and contracted state? So the first change in a contracted state is when the muscle contracts, two Z lines come closer. So Z lines come closer. See, when Z lines come closer, sarcomere decreases. Sarcomere decreases. The length of the sarcomere decreases. And number two, just imagine when two Z lines come close like this, what is happening to this H band? It becomes like this. See, H band decreases. So H band decreases. And what is happening to the I band? When the Z lines come closer and when actin moves closer, I band also decreases. What is happening to A band? A band is the band which contains, so this is A band, which contains the whole of myosin. Look at the relaxed state, look at the contracted state. In both the states, A band remains the same because myosin never moves. It is only the myosin head which pops up and moves the actin like this. So myosin never moves. That is why A band never changes. So the only band that does not change is A band. So this is again a repeatedly asked concept. Role of A gamma in contraction. See, we studied what is the role of A alpha. A alpha meets the muscle at neuromuscular junction, blah, blah, blah happens and the muscle is contracted. What is the role of this A gamma here? So let's do that now. So this is the muscle and you have spinal cord. From spinal cord, this is A gamma, which is innervating the intrafusal muscle fiber. So let me draw the spindle. This is a muscle spindle. Fibers inside the muscle spindle are called as intrafusal muscle fibers. So let me draw the intrafusal muscle fibers. See, when we draw the intrafusal muscle fibers, there are two types of intrafusal muscle fibers. Bag fibers and chain fibers. So I'll draw this one like a bag. This is a bag fiber. 1, 2. So two bag fibers. And let me draw chain fibers which look like a chain. 1, 2, 3, 4, 5. See, I have drawn typically 2:5 because once there was a question, what is the ratio of bag fiber to chain fiber? 2 bag fiber to 5 chain fibers. So these are the intrafusal muscle fibers. So when A gamma is activated, you know what happens when A alpha is activated? Neuromuscular junction and all that happens, muscle contracts. Extrafusal muscle fiber contracts. Now let's see what happens when A gamma is stimulated. So we have A gamma, which innervates the intrafusal muscle fiber. The intrafusal muscle fiber, especially bag fiber, has a more important role here. Actually, the intrafusal muscle fiber should contract now, but this contraction is somewhat different because look at the structure of this intrafusal muscle fiber. Its structure is such that it has contractile proteins only in the end. The center bag, listen carefully, the center bag does not have contractile proteins. It has contractile proteins only towards the end. So this portion will contract and become like this. This portion will contract and become like this. So when both the ends contract, what is happening to the center bag portion? It is stretched. So the center bag portion stretches. This stretch will trigger 1A type of nerve fiber from the bag. So you have 1A coming out of the bag, 1A, and goes to the spinal cord. And 1A, what it does, it ends on A alpha. Don't get confused here. The cycle started with A gamma innervating the bag, and when the bag stretches, 1A goes to the spinal cord, 1A ends on A alpha. And when A alpha is stimulated, what will happen? Extrafusal muscle fiber will contract. Contraction of extrafusal muscle fiber. And please keep in mind, muscle spindles are very small structures. It is not so big like this. So for an elaborated view, I have drawn it like this, but it is not like that. If you have a muscle like this, muscle spindles are very tiny structures like this, and they do not contribute that much to muscle contraction. Extrafusal muscle fiber contraction only is more important. So now I think you understood. A alpha causes direct contraction of extrafusal muscle fiber. A gamma causes indirect contraction of extrafusal muscle fiber. So both are causing contraction of extrafusal muscle fiber only. Okay, fine. Yes. So this is the role of A gamma in contraction. See, that is why you need alpha gamma coactivation. Only then you will have a smooth contraction. Yes, back to this question now. Following is an electron micrograph of a human skeletal muscle. So we'll mark the parts. This is Z line, and this is sarcomere, and this is dark band, which is A band. In the center of dark band, you have H zone, and attached to the Z line is the I band. So the answer is I band. Types of skeletal muscle fibers. You have type 1 and type 2. How do you easily remember this? Type 1 fibers are SOX fibers. SOX means S for they are slow. Slow means they are slow to contract and slow to fatigue. So for which type of muscle activity can you use these fibers? Slow to contract, slow to fatigue. Yes, endurance training like marathon runners. You need to run for a long distance, so it should not get fatigue. And OX for oxidative phosphorylation. They use oxidative phosphorylation for energy, which gives them the sustained contraction. And one more point about S is that they are small fibers, smaller fibers. Smaller fibers, slow fibers, oxidative phosphorylation. They are rich in mitochondria and myoglobin. See, when you have more of myoglobin, it will give you red color. That is why they are red in color. Just the opposite for type 2, fast to contract, fast to fatigue. So it is playing an important role in sprinters and weightlifters. It uses anaerobic glycolysis for energy. It has very less myoglobin, therefore no red color. It is white in color. Okay, questions are repeatedly asked from this topic also. So what are the major differences between skeletal muscle, smooth muscle, and cardiac muscle? See, in skeletal muscle, you have Z lines. But in smooth muscle, in the place of Z lines, you have dense bodies. Keep in mind, in the place of Z line, you don't have Z line in smooth muscle, you have dense bodies. And another difference is the major source of calcium in skeletal muscle is sarcoplasmic reticulum. The major source of calcium in smooth muscle is ECF. And in skeletal muscle, calcium binds to troponin. In smooth muscle, there is no troponin, so calcium binds to calmodulin. And a very special property of smooth muscle is its plasticity. Plasticity. Smooth muscle only has plasticity property. Cardiac muscle. So one special difference in cardiac muscle is that, say in skeletal muscle, when you talk about dihydropyridine and ryanodine receptors, so this is dihydropyridine. Dihydropyridine. In skeletal muscle, the dihydropyridine makes a physical contact or configurational change and it touches the ryanodine receptor, and this is what causes release of calcium from SR. So the configurational change between dihydropyridine and ryanodine, they physically touch each other, and this is what causes release of calcium from ryanodine. But in cardiac muscle, it's not like that. Dihydropyridine receptor itself acts like a calcium channel, long lasting calcium channel, and it causes entry of calcium. So entry of calcium through dihydropyridine receptor causes release of calcium from ryanodine receptor. So entry of calcium causes release of calcium. This is called calcium induced calcium released. Calcium induced calcium release. Very special property of cardiac muscle fibers. Yes, let's move on. True about cardiac muscle except is, what is the answer for this? Is anybody for the answer for this? Okay. A is the right answer. So for to answer this question, we need to discuss action potential curve of cardiac fibers. So already you know the action potential of nerve fibers. I'll just tell you what are the differences. In a nerve fiber, RMP value is minus 70. But in a cardiac ventricle, see in heart you have two types of fibers, your ventricular fibers and SA node fibers. So both are different. So the action potential is also different for both. So in cardiac ventricle, it is minus 90, RMP is minus 90, and in SA node, it is minus 55. And the other major differences are, look at the cardiac ventricle action potential curve. It is not like this, okay, as simple as a nerve. It's little complicated because it has a special phase called plateau phase, which is not present in the nerve. So it has depolarization, which is due to sodium influx, and repolarization, which is due to potassium efflux. And in between, you have a small plateau phase, which is called as phase 2. See, in phase 1 itself, potassium will start moving out. And in phase 3, potassium is completely moving out. But in between, in phase 2, what is happening? See, when potassium is starting to move out in phase 1, when repolarization is just started, there is opening up of L type of calcium channels. When L type of calcium channel opens, you have entry of calcium ions. So potassium is a positive ion moving out. Calcium is a positive ion moving in. So these two balance each other. So when these two balance each other, there is no change in the potential. That is why phase 2 remains as a plateau phase. So plateau phase is because of L type of calcium channel, and calcium channel blockers in medicine act on this phase only. And what about the speciality of SA node action potential? SA node action potential has this small slope here, which is called as slow diastolic depolarization phase, slow diastolic depolarization phase, or the pacemaker potential. And what is it due to? IF, TCAL, and NCX. IF means funny currents, which will let in sodium ions. TCAL is T type of calcium channel or transient calcium channel, which will also allow in calcium ions. NCX is sodium calcium exchanger, which will exchange calcium for sodium. So all these three channels are responsible for the slope phase, slow diastolic, slopey depolarization phase, which is not seen anywhere else. And this is the reason why SA node is able to produce the highest action potential or the fastest number of beats because of this slope which is present in the SA node pacemaker potential. Okay, yes. We'll move on to nervous system. So before that, over to this question. Phase 2 is due to calcium channel? Yes. Phase 3, potassium efflux? Yes. Tetany of cardiac muscle is never seen. See, cardiac muscle can never go for tetany. If cardiac muscle goes for tetany, person will die. So cardiac muscle never goes for tetany. The reason is it has a plateau phase. So when you have that plateau phase, this plateau phase, it tends to increase the refractory period. Okay, so it, because of this plateau phase, the refractory period increases. When refractory period increases, the muscle can't go for a sustained contracted state. It can't quickly produce more contractions and go for a contracted state. So tetany of cardiac muscle is never seen. The reason is it has a long plateau phase, which gives rise to a longer refractory period. Let's move on to nervous system. So in nervous system, we'll see what are the ascending and descending tracts. So before that, what are the sensations? Fine touch, vibration, proprioception, joint position sense, tactile localization, 2-point discrimination, stereognosis, graphesthesia. All these sensations are carried by dorsal column. Okay, I'll give you a question. We have a list of sensations here. Of all these sensations, what are the sensations that you want to cross over immediately? I don't want this. I want to cross over immediately. What are they? Yes, screw touch, itching, pressure, pain, and temperature. These are bad sensations that you want to cross over immediately. See, why am I telling you this is, remember, the tract which carries screw touch, itching, pressure, pain, and temperature, it starts here, goes to the spinal cord, crosses immediately in the spinal cord to the opposite side, which is called as spinothalamic tract. So remember like this, I don't want these sensations, I want to cross over immediately. So remember, it crosses immediately in the spinal cord itself. But fine touch, vibration, proprioception, joint position, they are all nice sensations. You need not cross over immediately. It can go up to the medulla and it can cross at the medulla. So dorsal column, from the spinal cord, it goes to medulla, crosses only at the level of medulla. And this is spinothalamic tract. So the point is, eventually all ascending sensory tracts will cross and go to the opposite side. And in spinothalamic tract, look at the spinothalamic tract. There are two spinothalamic tracts. Screw touch, itching, and pressure is carried by anterior spinothalamic tract or ventral spinothalamic tract. Anterior or ventral spinothalamic tract. Pain and temperature are carried by lateral spinothalamic tract. So how I used to remember this is pain and temperature, very bad sensations. So when you say no to pain and temperature, push pain and temperature laterally. You say no like this. So push it laterally, it goes laterally, carried by lateral spinothalamic tract. So remember, eventually all sensations reach the opposite side sensory cortex. The point is where they cross. A 15-year-old boy had a head injury while playing cricket. He was brought to the emergency ward in an unconscious state. Neurological examination was done. The boy was able to follow commands. So the hints here are he is able to follow commands. He was able to repeat words spoken to him, but he had difficulty in reading the book and in understanding pictures. So the problem with the boy is he is not able to read from the book and he's not able to understand the pictures. The affected area in the boy's brain is. So we will learn about disorders of speech and we'll go to the question. So what are the different speech disorders? Speech disorder is called as aphasia. So aphasia means, see, if you have an ulcer in your tongue and you're not able to speak, that is not called aphasia. If you have a lesion in the speech language area of the brain, then you are not able to speak, that is called as aphasia. So what are the different types of speech disorders? Wernicke's aphasia, Broca's aphasia. So what is Wernicke's area first of all? Area 22, Brodmann area 22 is Wernicke's area, and the function of Wernicke's area is comprehension. It helps. Comprehension means when somebody is telling you something, it is, see, I'm talking to you. If you are able to understand what I'm talking, it means your Wernicke's area is making a comprehension, an analysis of the meaning. That is comprehension. Broca's area. Broca's area is the motor area for speech because it connects to the motor cortex and it will help you in speaking out. It will help the muscles of the tongue and the lips to speak out. So that is motor area. So when you have damage to this area 22, most commonly seen in infarct to the inferior branch of middle cerebral artery, it results in Wernicke's aphasia. When you have infarct to superior branch of middle cerebral artery, Broca's aphasia. You can even remember like this. Broca's area is located superiorly. Wernicke's area is located inferiorly on the temporal lobe. So superior branch, inferior branch. When both are affected, global aphasia. Then what is conduction aphasia? There is a connection between Wernicke's area and Broca's area. A bridge. That bridge is called as arcuate fasciculus. If that bridge is damaged, it results in conduction aphasia. So you're not able to conduct between Wernicke's and Broca's area. Damage to angular gyrus. See, angular gyrus is another special area which is important for reading from printed words. Reading from printed words. Printed words in the sense reading from a book, reading from laptop, reading from the board. For all this, you need angular gyrus. So when angular gyrus is damaged, it results in three forms of disease. One is dyslexia and alexia, which are reading disorders or learning disability, you can say. If you have seen the movie 𝗲𝗏𝗄𝗃, you will see that Amir Khan is with a small boy there who's not able to read from the board. He's not, all the numbers and alphabets will look like, they will dance like animals for him because he has dyslexia. It is a developmental disorder where you're not able to read from printed words. Alexia is if the boy is able to read till his 10th standard. In his 10th standard, he has some accident and his angular gyrus is damaged. From 11th class onwards, he will not be able to read from books. That is alexia, acquired form. Another function of angular gyrus is naming objects. So when you have damage to angular gyrus, you will not be able to name objects. That is called anomic aphasia, a naming disorder. So if you show this pen and ask him what is this, he'll be able to describe it as a long tube which is used for writing. You can keep it in the pocket, but he will not be able to call it as or name it as a pen. That is called anomic aphasia. And most important table, difference between Wernicke's and Broca's aphasia. Wernicke's aphasia, damage to area 22. Broca's aphasia, damage to area 44-45. Where is Wernicke's area located? Posterior end of superior temporal gyrus, in the temporal lobe. Broca's in the inferior frontal gyrus. Wernicke's area, see, Wernicke's only is sensing the meaning of the word. So it is sensory area. Broca's is speaking out, so motor. So it helps in comprehension. Vernix, Broca's helps in producing motor speech, and Vernix area receptive aphasia, because Vernix only receives the word, so damage can cause receptive aphasia. It senses the word, so damage can cause sensory aphasia. Broca's aphasia expresses the word, so damage can cause expressive aphasia, motor aphasia. So in Vernix aphasia, comprehension is completely lost. So you'll not the person will not be able to understand what you say. But if you ask him to repeat or talk to you, he will talk fluently because Broca's is fine, no? So fluency is not lost. Fluency is fine. So that's why it's called fluent aphasia. So for example, if I'm going to ask him to say Betty bought some butter, the butter was bitter. So Betty bought some more better butter to make bitter butter, better butter. How will a Vernix aphasia patient say this? So he'll just say it as Betty, 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 because he's not able to understand anything. But he wants to talk fluently, he'll talk some nonsense. So it will be a meaningless, excuse me, meaningless fluent talk that is seen in Vernix aphasia. But in Broca's aphasia, comprehension is not lost, but fluency is lost. So he'll be able to understand the meaning of whatever you said. But if you ask him to repeat, he won't have fluency. So it will be a non fluent but meaningful because he understood the meaning. So how will a Broca's aphasia patient repeat that? Betty, bought, so some, butter. Yes, that's called stuttering speech or stammering speech, which is seen in Broca's aphasia. Very important table. Repeatedly questions are asked from this concept. Yes, hope you're clear with this. Yes, now the answer is reading difficulty, angular gyrus. It is not Vernix because he's following commands, he's understanding, he's analyzing. So Wernicke is not the answer. Broca's, he's able to repeat the words. When you're repeating, it means he's speaking. So Broca's is not affected. Reading is affected. So angular gyrus. In a small stimulus causes more pain. It is called. Okay, in case a small stimulus causes more pain. This is about the different types of pain disorders. Yes, you're right. The answer is hyperalgesia. Let's have a look at the disorders of pain. So, in disorders of pain, see when you say algesia means you're talking about pain. When you say aesthesia, it means you're talking about all sensations, not only pain, all sensations. So, in algesia, you have hyperalgesia, hypoalgesia, and analgesia. So, what is the basic difference? See, the stimulus in all three is a painful stimulus. So, the stimulus is painful stimulus. So, here also it is painful stimulus. Here also it is a painful stimulus. But the response differs. If you have increased pain response, that is hyperalgesia, decreased pain response, hypoalgesia, loss of pain, that is analgesia. But remember, the stimulus in all three is painful stimulus. What about another terminology called allodynia? Allodynia. See, the difference between hyperalgesia and allodynia is, in hyperalgesia, a painful stimulus is producing exaggerated pain. For example, if a mosquito is biting you or a bug is biting you, it can produce pain. But if you're going to shout and gather crowd for that, it's called hyperalgesia. Painful stimulus only, but it should not produce an exaggerated pain response. That is hyperalgesia. But allodynia is, if I touch you with a feather, it is paining for you. That is called allodynia. So a non-painful stimulus is causing increased pain. That is called allodynia. Touching with a feather or taking a warm shower. All these are examples for allodynia. So these are all related to algesia. And what about aesthesia? See, when you say aesthesia, I'm talking about all sensations, not only pain, touch, pain, temperature, all sensations. Hyperaesthesia, hypoaesthesia, anesthesia. So hyperaesthesia is increased sensitivity to all sensations. To all sensations including pain. Touch, temperature, pain, pressure, vibration. Hypoaesthesia is decreased sensitivity. Anesthesia is loss of all sensations. Okay, don't confuse between algesia and aesthesia. So in case a small stimulus causes more pain, it is called hyperalgesia. What is causalgia? See, causalgia is when you don't know the cause of pain, that's called causalgia. You might have had a nerve injury 3-4 years back, and now you're having sympathetic adrenergics developing around that nerve and it is causing pain. So you don't even remember the injury which happened long back. So without cause, you think that there is a pain. That is called causalgia. Yes, let's move on to sleep physiology. Yes, the first thing I do when I wake up is try to sleep again. Yes, all of us do this. So before moving on to sleep physiology, you should know how are you remaining awake. That is called ascending arousal system or reticular formation. So certain hormones in the brain or certain neurotransmitters in the brain are increased and certain neurotransmitters are decreased for you to remain awake. So in awake state, when you are awake, what is that? There's a query. Stimulus is painful or painless. In allodynia, okay, in the previous question you're asking. Okay, in previous question, in case a small stimulus causes more pain. Okay, actually it should have been a small painful stimulus. Painful stimulus only, doctor. Okay. So awake. So when you are awake, what are the neurotransmitters levels that are decreased? Okay, let's see that first. Acetylcholine. I'm not talking about the muscle, I'm talking about the brain. Okay, so acetylcholine levels in the brain decreases and adenosine decreases, GABA decreases. So these three neurotransmitter levels are decreased. What about the other neurotransmitters? Histamine, orexin levels are increased. 5-HT, 5-hydroxytryptamine is serotonin levels are increased. Dopamine is increased. Noradrenaline is increased. So all these are changes in the neurotransmitters happening when you are awake. Just the opposite happens when you sleep. Okay. So during sleep, acetylcholine, adenosine and GABA will increase. All others will decrease. So a switch over of the neurotransmitter level is responsible for sleep-wake cycle. So what are the stages of sleep? So when you say good night and when you go to sleep, you enter sleep in non-REM sleep. There are two types of sleep: no rapid eye movement sleep and rapid eye movement sleep. When you fall asleep, you enter sleep in non-REM sleep. And when you say good morning and when you get up in the morning, you get up from REM sleep. So altogether, non-REM and REM will keep occurring intermittently throughout the night. It will be switching over non-REM, REM, non-REM, REM. Totally, if you see, 75% will be contributed by non-REM sleep and 25% by REM sleep. So in between throughout the night, every 90 to 110 minute cycle keeps changing. That is called ultradian rhythm. Ultradian rhythm. Circadian rhythm is maintaining a 12-hour awake and 12-hour sleep, 24-hour cycle is circadian rhythm. This is ultradian rhythm. What are the differences between non-REM sleep and REM sleep? Okay, we'll see the major differences. Non-REM sleep is called as quiet sleep. Why is it called quiet sleep? Because you're sleeping quietly without sympathetic activity. So sympathetic is inhibited. Sympathetic inhibition. And in REM sleep, it's called active sleep because your sympathetic is active. When your sympathetic is inhibited, automatically heart rate goes down, cardiac output goes down. When sympathetic is active, your heart rate is up and cardiac output is up. And what are the other things that happen during non-REM sleep? See, when you say non-REM sleep, you can say not, you can remember it like this: not remembered. What is not remembered? Dreams are not remembered. And when you say REM sleep, remembered. What is remembered? Dreams are remembered. And especially when you have a bad dream during REM sleep, you will get up from the bed and you will shout and you will have palpitations. So that is called a nightmare. And why are you having palpitations? Because already sympathetic is active in your REM sleep. On top of that, if you have a very bad dream, it produces nightmare. And what are the other things that happen during the night and you don't remember? Sleepwalk, sleep talk, sleepwalking, sleep talking, sleep bruxism, teeth grinding, sleep enuresis, bedwetting. And for all this to happen, you need muscle tone. So muscle tone is slightly decreased. But in REM sleep, muscle tone completely lost except for your eye muscles and respiratory muscles. Muscle tone is completely lost. So these are the differences between non-REM and REM sleep. And another disorder where you have problem with orexin producing neurons in the hypothalamus, a disease called narcolepsy, where the patient can skip the initial non-REM sleep and directly enter REM sleep. So when you skip the non-REM sleep and directly enter the REM sleep, what happens? Your muscle tone is completely lost and suddenly you close your eyes and you fall down like that. Actually, you should go through non-REM sleep and then only you should enter REM sleep. But in narcolepsy, the person has disturbance of initial non-REM sleep. So directly enters into REM sleep, complete muscle tone is lost. So he falls asleep like that. So daytime sleepiness, you can see excessive daytime sleepiness, the patient will fall asleep. Okay, he may even fall on the ground. That is called cataplexy, seen in narcolepsy. Sleep waves and EEG. So how can you correlate this easily? When you connect electrodes over the scalp and you record the EEG waves throughout the sleep, you can see different types of waves. So the mnemonic here is: at night, bats drink blood. So at night tells you that it is the sleep waves. Bats, BATS, drink blood. So when you ask the patient to sleep and you're going to record the electrical activity of the brain. So when he's awake, first of all, okay, so how do you sleep? You do, when you go to your bedroom, you don't sleep off like that. First of all, you will stay awake for some time with your eyes open. So eyes open. At that time, you record beta waves. Then you will try to sleep. You will close your eyes and you will try to sleep. You will stay in a relaxed state and you will try to sleep. So at that time, you record alpha waves. Now only you're going to enter into the actual sleep. So you enter in non-REM stage 1. Then you go to non-REM stage 2. And then you enter non-REM stage 3. So in non-REM stage 1, you record theta waves. In stage 2, you record sleep spindles and also K complex. And non-REM stage 3, you record delta waves. REM sleep. And during REM sleep, you record beta waves. And beta waves are actually recorded when your eyes are open. Then why should you record beta waves during REM sleep? That is a paradox. That paradox means something which is controversial. That is why REM sleep is called paradoxical sleep. And what about the height and frequency of the waves? Beta waves have the highest frequency. See, they occur more frequently, but they have the lowest height or lowest amplitude. Delta waves have the highest amplitude, see, tall waves, but lowest frequency. And a few other important points are non-REM stage 2. Typically, you can see bruxism in non-REM stage 2, teeth grinding. And I told you non-REM contributes to 75% of the sleep. Of the 75% of the sleep, 50% is contributed by non-REM 2. Okay, so these are all possible questions from sleep waves. And there's one more phenomena called arousal phenomena or alerting response. So just imagine you're closing your eyes and you're in a relaxed state with alpha waves. You're trying to sleep. Suddenly, if your exams come to your mind, you will wake up like that, and alpha waves change into beta waves. So that is called alpha block. Alpha block or arousal response or alerting response. Yes, we have completed sleep physiology. We'll move on to another important topic, cerebellum. So the anatomy of cerebellum, you have the lateral halves, which is called as cerebrocerebellum, and the middle half is called spinocerebellum. In the center of spinocerebellum, you have vermis. And what is the function of cerebrocerebellum? It receives the planning from the motor center, and spinocerebellum connects to the spinal cord, and it is going to check for your coordination. What about the nuclei? So deep inside you have nuclei. Our mnemonic to remember the nuclei is doctors eat good food. See, the mnemonic is important because you need to remember them from lateral to medial. So the lateral most nucleus is D, dentate. Then you have emboliform. Then globose and fastigial. So medial most nuclei is fastigial. And fastigial has two important functions of saccades and pursuit. So saccades and pursuit are kind of eye movements. So saccade is when you look at the laptop screen, see your eyeball jumps from here to here. Looking at a laptop screen is an example for jumping movement of the eyeball, saccades. Pursuit is, see, when you look at a beautiful girl who's crossing the road from this side to that side, see, look at the girl like this, continuous movement without taking off your eyes. So the continuous eyeball movement is called as pursuit. So this is about cerebellum and connections of cerebellum. So few questions are asked about connections of cerebellum. So in cerebellum, you have cerebellar cortex, which has 5 types of cells: granular cell or granule cell, Golgi cell, basket cell, stellate cell, and Purkinje cell. And what about the connections? Granule cell gives an excitatory connection to all other cells. But Golgi cell, it inhibits the granule cell. See, it's getting positive from granule cell and it is backstabbing the granule cell itself. That's why it is called feedback inhibition. Feedback inhibition. What about stellate cell and basket cell? They are inhibiting the Purkinje cell. So they remember like this, they're going forward and inhibiting the Purkinje cell. So it's called feed forward inhibition. And the Purkinje cell inhibits the deep nuclei which is inside. Deep nuclei. So on a whole, if you take the cerebellum, this is all the connectivity inside the cerebellum. From outside, how is it connected to the outside? So from outside, it receives positive input and also the nuclei will give out positive output. So as a whole, the inputs into the cerebellum are positive, outputs from the cerebellum are also positive. And what are these two inputs named as? Climbing fiber. And to be more specific, climbing fiber actually connects to Purkinje cell. And this is called 𝗲𝗄𝐶 fiber. And 𝗲𝐶 fiber connects to granule cell. And if you compare climbing fiber and 𝗲𝐶 fiber, one climbing fiber will connect to one Purkinje fiber. So it is a 1:1 strong connection. So you'll get strong spikes. But 𝗲𝐶 fiber, one 𝗲𝐶 fiber will connect to 1 million granule cell. So it is a 1:1 million weak connection. Or you can say it produces weak potentials if you try to record. So this is about the connections of cerebellum and the possible questions from your. Yes, let's move on to renal physiology. So in renal physiology, let's learn about the tubular transport mechanisms. So in tubular transport mechanisms, so most of the questions are asked from which part of the tubule is reabsorbing which salt or which ion, or water is reabsorbed maximally where, or which diuretic acts on which part of the tubule. So most of the questions in renal physiology are from tubular transport mechanisms. So let's learn the tubular transport mechanisms. So follow this carefully. So we will learn part by part. First, let's learn about PCT in proximal convoluted tubule. Let's consider this as a single cell of PCT. Let's see what is happening. So it has an apical side. So this is the apical side. The side facing the blood is called as basolateral side, basolateral membrane. 60% sodium, chloride, potassium, and water is reabsorbed. 60 means it's not exactly 60, it's around 60 to 70. Some books tell you 65, some books tell you 70. So for an ease of remembrance, I've kept it as 60. Okay. So you find that maximum salt and maximum water reabsorption takes place in the PCT, 60%. So let's see how sodium is reabsorbed through sodium glucose transporter, which is called SGLT2, sodium amino acid transporter, sodium lactate transporter, and sodium phosphate transporter. So all these four are secondary active transporters or even secondary active symporters, because sodium and the substance is moving in the same direction. But you have sodium hydrogen exchangers. Sodium hydrogen exchanger, where sodium moves inside and hydrogen moves out. And maximum contribution of sodium reabsorption is by sodium hydrogen exchanger. And sodium is accumulated inside the cell. On the other side, it is absorbed into the blood through sodium potassium ATPase. What about chloride and potassium? So most of the chloride and potassium is reabsorbed in between the cells. You have paracellular space, it is reabsorbed through paracellular diffusion. What about water? Water is reabsorbed through water channels called aquaporin 1. On the other side, also through aquaporin 1 into the blood. 50% urea is dragged along with water, that is called solvent drag. 70% calcium reabsorption, it occurs through proteins called claudin 2. 80% phosphate reabsorption, 90% bicarbonate. Bicarbonate reabsorption is important because you don't have any special channels for bicarbonate reabsorption, but still bicarbonate is reabsorbed. How? Bicarbonate, when it is filtered, it combines with the H plus, which moved out through the sodium hydrogen exchanger to form carbon dioxide and water. This carbon dioxide is a gas. It now diffuses into the cell. Inside the cell, it combines with water to form H plus and bicarbonate with the help of enzyme carbonic anhydrase. And hydrogen is exchanged through sodium hydrogen exchanger, and bicarbonate moves through sodium bicarbonate transporter. If you block this carbonic anhydrase inhibitor, what are the drugs? Yes, they can act as diuretics. 100% glucose, amino acid and proteins are reabsorbed. How is glucose reabsorbed? Through SGLT2, and on the other side through GLUT2. It is important to remember that on the apical side it is SGLT2, which is a secondary active transporter. On the basolateral side it is GLUT2, which is a type of facilitated diffusion. And what happens if you block SGLT2? So if you block SGLT2, you are blocking glucose reabsorption. So it can use it in the treatment of diabetes mellitus, SGLT2 blockers, gliflozins, empagliflozin, canagliflozins, they are all SGLT2 blockers. What about the tonicity of the fluid which leaves the PCT? See, salts, water, both are proportionately reabsorbed, 60%. So no change in the concentration of the fluid. So it is isotonic. And one last function here is formation of ammonia from glutamine. This ammonia is useful for neutralizing this H plus. So for easily remembering only, I have rounded off the numbers to 50, 60, 70, 80, 90 and 100. Okay. List of carbonic anhydrase inhibitors: dorzolamide, methazolamide, brinzolamide, dichlorphenamide, SGLT2 blockers, canagliflozins, dapagliflozins, and empagliflozin. And keep in mind, sotagliflozin can block SGLT2 1 in the intestine and 2 in the kidney. So you should be very careful if you prescribe sotagliflozin. Osmotic diuretics also act in the PCT. What is osmotic diuretic? Osmotic diuretics prevent the reabsorption of water. When water is not reabsorbed, water stays in the lumen and it moves out in the urine, giving you an osmotic effect. So when you give substances like mannitol, they will inhibit the water reabsorption and they will cause osmotic diuresis. So osmotic diuretics also act at PCT. So next, let's move on to the descending limb of loop of Henle. So in descending limb of loop of Henle, you have only one channel for water reabsorption. So here you don't have any channels for any other ions. So descending limb of loop of Henle is our friend. Very easy to learn. Only water channel, aquaporin 1, through which water is reabsorbed. How much of water is reabsorbed? 15% of water is reabsorbed. And this segment is completely impermeable to salts. See, when you say it is impermeable to salts, it means that the fluid which leaves this portion, water would have been reabsorbed, salt still remains in the fluid itself. So the fluid which leaves this descending limb will be rich in salts, or I can say it is hypertonic. But the fluid which moved out of PCT is isotonic. This is hypertonic. And when this hypertonic fluid, which is rich in salts, reaches the ascending limb has two portions, initial thin portion and later thick portion. And when this travels through the thin ascending limb, it is already hypertonic. Okay, it is rich in salts. So you don't need any active transporters. It can be easily passively reabsorbed. So there is passive reabsorption of salts. The next segment, which is the thick ascending limb or the TAL segment, 25% sodium chloride and potassium is reabsorbed. So this is also not going to complicate us because sodium, potassium and calcium, sodium, potassium and chloride, all three are reabsorbed through one single channel, which is called NKCC, sodium, potassium, chloride channel. So through this, sodium is reabsorbed, potassium is reabsorbed. This potassium is again recycled through 𝗏𝗃 channels, renal outer medullary potassium channels. Chloride is reabsorbed and chloride moves out into the blood through 𝗙Ce_𝗂𝗃 channel. And TAL segment is completely impermeable to water. What if you block this NKCC? Yes, loop diuretics. They can act as loop diuretics. What is the tonicity of the fluid which leaves the TAL segment? See, the TAL segment impermeable to water, just the opposite of descending limb. So it has reabsorbed salts, it is impermeable to water. So it will keep water in the lumen, therefore diluting the fluid. So it becomes hypotonic. That is why this segment is called as diluting segment. 10% of bicarbonate reabsorption takes place. So 90 in the PCT, the remaining 10% is taking place here. And you have a disease here. It's called Bartter syndrome. Loss of function of NKCC or 𝗙Ce_𝗂𝗃 or 𝗏𝗃 or Barton protein, which is important for these channels, can result in Bartter syndrome. So there are four types of Bartter syndrome. Type 1, mutation of NKCC, type 2, mutation of 𝗏𝗃, type 3, mutation of chloride channel, and type 4, Barton mutation. Next, let's move on to early DCT. So in early DCT also, we have only one channel, one important channel for sodium chloride reabsorption, through which 7% of sodium chloride is reabsorbed. So here only you have the effect of first hormone, aldosterone. So aldosterone is called salt hormone. Why? Because it increases the activity of this sodium chloride channel. So it is called salt hormone. It will increase the salt reabsorption. Drugs which block this sodium chloride channel, thiazide diuretics. One more important event that takes place in the early DCT is calcium reabsorption through calbindin D28. So what is special about this? Parathormone and vitamin D dependent calcium reabsorption takes place through this sodium chloride channel. Takes place at the early DCT with the help of calbindin D28. Loss of function mutation of this sodium chloride channel can result in Gitelman syndrome. So in TAL segment, it was Bartter syndrome. In early DCT, it is Gitelman syndrome. Keep in mind, Bartter and Gitelman are loss of function mutation. So the cortical collecting tubule. So the cortical collecting tubule and the late DCT share common properties. It is made up of two types of cells, I cell or intercalated cell, P cell or principal cell. So first let's learn about I cell. There are two types of I cell. Type A I cell A for acid secretion. Type B I cell, B for bicarbonate secretion. What about P cell, principal cell? So this is only more important for us. 3% of sodium chloride reabsorption takes place through a special channel called ENaC. ENaC is important because you have blockers of ENaC which are used as drugs. So what is the function of ENaC? Epithelial sodium channel. So it will help you to absorb sodium, and the accumulated sodium inside the cell moves out through sodium potassium ATPase. And in exchange for sodium which left the cell, potassium moves inside, and this potassium is secreted into the lumen. So the next function of cortical collecting tubule is potassium secretion. For sodium which is reabsorbed, potassium will be secreted. So here also you have the effect of hormone aldosterone. Aldosterone increases the activity of ENaC. And what is that blocker of aldosterone? Aldosterone antagonist, spironolactone. And what is that blocker of ENaC? Amiloride. What is special about spironolactone and amiloride? Both are potassium sparing diuretics. Potassium sparing diuretics. Why potassium sparing diuretics? When they block ENaC, sodium cannot be reabsorbed. When sodium is not reabsorbed, potassium cannot be secreted. So potassium is spared from being secreted. That's why they are called potassium sparing diuretics. We have a disease here also. Gain of function of ENaC results in Liddle syndrome. So keep this in mind. Only Liddle syndrome is gain of function mutation. Barter's and Gitelman were loss of function mutation. So what would be the clinical presentation of Liddle syndrome? If it's going to be a gain of function of ENaC, more sodium is reabsorbed. When more sodium is reabsorbed, it will result in hypertension. So Liddle syndrome presents with hypertension. Yes, the last part, medullary collecting tubule. In medullary collecting tubule also you have P cell, and here you have the effect of another hormone, antidiuretic hormone or vasopressin. Antidiuretic hormone or vasopressin attaches to V2 receptor. When it attaches to V2 receptor, it causes insertion of water channels called aquaporin 2, through which water is reabsorbed, and on the other side through aquaporin 3 and 4. So here you should remember that only aquaporin 2 is vasopressin dependent, not 3 and 4. So water is reabsorbed. Nearly 10 to 13% of water reabsorption takes place like this. So if you don't have vasopressin, as in diabetes insipidus patients, only this 10 to 13% of water reabsorption will be affected. So diabetes insipidus patients, they'll have a urine volume of nearly 18 to 20 liters. Vasopressin also increases the activity of urea transporter, type A1 and type A3. So urea transport also takes place in the medullary collecting tubule. So a summary of disorders of tubular transport proteins: Barter, Gitelman, Liddle. Only Liddle is gain of function mutation. So remember, if you arrange it in the ascending order, B comes first, then G, then L. Two other important concepts here are glomerulotubular balance and tubuloglomerular feedback. So first, let's see what is glomerulotubular balance. So this is the glomerulus. When the glomerulus filters more, so when there is increased GFR, glomerulo, the tubule will reabsorb more, especially PCT. So proportionate increase in reabsorption of solutes. This is called glomerulotubular balance. Increased GFR in the glomerulus, increased reabsorption in the tubule. If suppose this fails to happen, what will happen? This increased GFR flows all along the tubule and it will reach this portion. And in this portion, so that portion is between the afferent and the efferent arteriole. So if you look at the structure of every nephron, the junction between thick ascending limb and the distal tubule will meet the glomerulus between the afferent and the efferent arteriole. In this place, you have cells called macula densa. What will this macula densa do? So if suppose glomerular tubular balance did not take place, all of this GFR will pour into the macula densa. And now this macula densa senses the sodium chloride. So you can see the blue colored cells which are macula densa present between the afferent and the efferent arteriole. So whenever there is increased GFR, there is more sodium chloride in the tal segment that is sensed by macula densa. Sodium chloride enters the macula densa and there is increased sodium ATPase, sodium potassium ATPase activity. Why? See, every cell will have sodium potassium ATPase. So when sodium enters the cell on one side, it will leave the cell on the other side through sodium potassium ATPase. So when sodium potassium ATPase activity increases in the macula densa, ATP hydrolysis, which will release adenosine, and adenosine is going to cause release of calcium, and this calcium is released into the nearby afferent arteriole. Afferent arteriole has smooth muscles. So calcium, when it acts on the smooth muscles, it will cause constriction of this afferent arteriole. So afferent arteriole constricts. When afferent arteriole constricts, GFR, blood flow itself will decrease. So GFR decreases. See how an increase in GFR causes a decrease in GFR. This is called tubuloglomerular feedback. So site of action of hormones. So most importantly, on the afferent arteriole, you have the effect of hormone angiotensin 2, which causes constriction of the afferent arteriole. And number 2, ANP, atrial natriuretic peptide, which is going to cause more sodium in urine. That is called natriuresis. So it will dilate the afferent arteriole. The other hormones you know already. Aldosterone acts on the DCT and collecting tubule. ANP also acts on the collecting tubule. And in the medullary collecting tubule, you have vasopressin or ADH. So these are the hormones which act on the nephron and the point at which it acts. Yes, let's move on to respiratory physiology. So questions are asked from major transport form of gases. So in transport form of gases, first let's see oxygen. So from the alveoli, when oxygen moves into the blood, you have RBCs. 97% of this oxygen binds to hemoglobin and only 3% stays as dissolved form in the plasma. So what is the importance of this dissolved form? Dissolved form only is contributing to the partial pressures. The bound form will help you to carry oxygen to the tissues. So the major transport form of oxygen is hemoglobin. What about carbon dioxide? Carbon dioxide is released by tissues. So it's actually released into the venous blood. So carbon dioxide, when it enters the venous blood, 7% remains as dissolved form in the plasma itself. and remaining enters into the RBCs. Inside RBC, carbon dioxide combines with water to form H plus and bicarbonate. So 70% transport form is by means of this bicarbonate, and some carbon dioxide also combines with hemoglobin to form carb amino compounds. Carb amino compounds. So 23% is transported like this. So major transport form of carbon dioxide is as bicarbonate form. Control of respiration. So in neural control and chemical control, first let's look at neural control of respiration. In neural control of respiration, we have several centers for respiration, medullary centers and centers in the pons. So in medullary centers, we have three important centers: pre-Bötzinger complex, dorsal respiratory group, and ventral respiratory group. So what is this pre-Bötzinger complex? The pre-Bötzinger complex is the pacemaker of respiration. See, pacemaker means it is the center which produces the first inspiratory rhythm comes from the pacemaker, like the SA node and like the interstitial cells of Kajal in the GIT. Here it is the pre-Bötzinger complex which produces the first impulse. And then you have dorsal respiratory group. Dorsal respiratory group is responsible for inspiration. Ventral respiratory group. Ventral respiratory group is responsible for expiration, but not normal expiration. Because for normal expiration, do you need any muscle or do you need any stimulus? No, it's a passive process. So this is needed for forced expiration. So these are the medullary centers. Then you have pons centers, pneumotaxic center and apneustic center. Pneumotaxic center, it is like a switch between inspiration and expiration. And apneustic center, it prolongs inspiration and causes apnea. So what if you have damage to these centers? When you have damage to pacemaker, so the involuntary control of rhythm itself is gone. So the patient will have to breathe only voluntarily. That is called Ondine's curse. Ondine's curse. So when you're awake, you can breathe voluntarily, but when you sleep, patient will die. So you have to put him on the ventilator if the patient wants to sleep. That is called Ondine's curse. And if you have damage to pneumotaxic center, the switch is lost. So you won't know when to switch between inspiration and expiration. So gradually, respiration itself will slow down. So slow respiration. So when you breathe slowly, your tidal volume increases. Therefore, tidal volume increases. So this is about neural control of respiration. What about role of vagus in respiration? Another repeatedly asked question. See, vagus has the role of inhibiting inspiration. Inhibiting inspiration. So that is why whenever you have damage to vagus, there's nobody to inhibit inspiration. So you will have an increased depth of respiration. Increases the depth of respiration. This is damage only to vagus. Another important point to be noted here is vagus and pneumotaxic center. Vagus and pneumotaxic center both have common roles of inhibiting inspiration, because pneumotaxic center will inhibit inspiration and take it to expiration. It's a switch, no? So that will also inhibit inspiration, and both will inhibit apneustic center. Both will inhibit apneustic center. So listen carefully. When you have a damage to both vagus and pneumotaxic center, now there is nobody to inhibit the apneustic center. Therefore, results in apnea. So when will you have apnea? When you have damage to pneumotaxic center plus vagus is also cut, you will have apnea. Only vagus is damaged, increased depth of respiration. Only pneumotaxic center is damaged, slow respiration with increased tidal volume. Okay. Yes, chemical control of respiration. So in chemical control, you have chemoreceptors. You have central chemoreceptors. Central chemoreceptors. C for C. It responds to changes in carbon dioxide. When your carbon dioxide levels increase, central chemoreceptors will be activated. Peripheral chemoreceptors. So what are the peripheral chemoreceptors? Carotid body and aortic body. See, you have an O here and O here. So two O's. So remember like this, O2. So whenever there is a fall in O2 levels, peripheral chemoreceptors will be activated. But keep in mind, this carbon dioxide, it can't act as such. It will cross the blood-brain barrier and it will enter the brain and it will combine with water to form H plus and bicarbonate. This H plus only will activate your respiratory centers. So central chemoreceptors are sensitive to CO2 and H plus. Peripheral chemoreceptors, whenever there is a fall in O2 levels, it will be detected by glomus cells and they will trigger two nerves, your glossopharyngeal and vagus, 9th and 10th cranial nerves, which will stimulate your respiratory centers. So they will stimulate the respiratory centers. Peripheral chemoreceptors, they are not only sensitive to oxygen, but also to CO2 and H plus. Keep this in mind, okay? Central chemoreceptors sensitive to CO2 and H plus. Peripheral chemoreceptors most sensitive to a fall in oxygen levels, but also to CO2 and H plus. Which of the following statement is true about functional residual capacity? Yes, what is the answer for this? Okay, we'll learn about the capacities and we'll move on to that question. Static lung volumes and capacities. See, what are static lung volumes and capacities? See, the easiest possible way to learn these values is to do them. Okay, so please do it along with me. So let's take a normal tidal volume. See, take a normal tidal breath. Normal breathing is tidal volume. You can take in 500 ml like this during inspiration and during expiration. That is tidal volume. On top of tidal volume, how much ever I'm taking as a reserve, that is inspiratory reserve volume, 2 liters. Now do a normal tidal expiration. After that, how much ever you can push out, expiratory reserve volume, 1 liter. After you do all this, 1.3 liter will stay as a residue inside the lungs itself. That is called residual volume. And a sum of all this is called as total lung capacity. It will almost come up to 5 to 5.5 liters. And what is vital capacity? See, of all these volumes, which is not vital for us, which is not important for you, residual volume, because it is staying inside, it is not important. So vital capacity will not include only the residual volume. So if you leave out residual volume, that is vital capacity. There are two other capacities here. Inspiratory capacity and functional residual capacity. Inspiratory capacity and functional residual capacity. So what is inspiratory capacity? See, your total capacity to inspire is called as inspiratory capacity. So as a tidal volume, you take in 500 ml. On top of that, you take in 2 liters. So total inspiratory capacity is tidal volume plus inspiratory reserve volume. What is functional residual capacity? Your residual volume plus expiratory reserve volume is called as functional residual capacity. Expiratory reserve volume, expiratory reserve volume plus residual volume. This is called as functional residual capacity. So how do you measure these capacities and volumes? So we can measure these capacities and volumes by using this method called spirometry. It's a machine which has a tube which is connected to the mouth, and you breathe in into the tube, closing your nose piece. So that is called as spirometry method. It can measure all the lung volumes and capacities, but residual volume cannot be measured by this method. Why? Because residual volume is, you are not breathing out residual volume, it's staying inside. So it does not go into the machine. So you cannot measure this. When you cannot measure residual volume, you cannot measure functional residual capacity. When you cannot measure functional residual capacity, you cannot measure total lung capacity. So how are you going to measure all these? All this can be measured by 3 techniques: helium dilution method, nitrogen washout method, and body plethysmography. So residual volume can be measured by helium dilution method, nitrogen washout method, and body plethysmography. So now, which of the following statement is true about functional residual capacity? So you breathe out normally. After that, you have expiratory reserve volume and residual volume. Together, it is called functional residual capacity. So the volume remaining after normal expiration. See, I told you, when you try to do this breathing exercise or practice, when you do tidal volume, when you do an inspiratory reserve volume, you'll never forget the definitions. Okay. Oxygen hemoglobin dissociation curve. So in oxyhemoglobin dissociation curve, the most important points to remember here are, first of all, you need to know some normal values. So what are the normal values from the curve? On x-axis, you have partial pressure of oxygen, and on y-axis, you have oxygen saturation of hemoglobin. So on x-axis, you have partial pressures of oxygen. At a partial pressure of oxygen 100, look at the y-axis. Oxygen hemoglobin saturation is nearly 90%. So when your PO2 is 100, oxygen hemoglobin saturation is nearly 97%. This is normal. When this 100 falls to 60, look at the saturation now. It does not fall that much. It falls only to 90. When your PO2 falls to 60, oxygen saturated with hemoglobin falls only to 90%. So what does this tell you? Even if your saturation goes to 60%, Oxygen hemoglobin, even if your partial pressure of oxygen falls to 60%, oxygen hemoglobin saturation will be maintained at 90%. This is called as safety factor. And one more value, at 27 millimeters of mercury partial pressure of oxygen, you will have 50% saturation. So when partial pressure of oxygen is 27 millimeters of mercury, oxygen hemoglobin is 50% saturated. So this is called P50. The partial pressure at which oxygen and hemoglobin is 50% saturated is called as P50. And about the shift of the curves, see, sometimes the curve shifts to right like this, or sometimes it shifts to left like this. So when will you have right shift and left shift? So how can you easily remember right shift and left shifts? So right side shift R, okay, release of oxygen to tissues, release of oxygen to tissues. So right shift means oxygen is being released to the tissues. What are the factors which cause right shift? See, when you say right, right means something positive. No? We'll put all positive factors. Increase in CO2, increase in H plus, increase in temperature, increase in 2,3 BPG, hypoxia. Because in hypoxia, you need oxygen to the tissues. So hypoxia also releases oxygen to the tissues. And what is this effect called? Another R. R for Bohr effect. Right shift, release of oxygen to tissues, Bohr effect. Okay. Left. What do you mean by left? Tissues are left without oxygen. It means more oxygen is with hemoglobin. So tissues are left without oxygen. Tissues left without oxygen. Another L. Another L for Haldane effect. L for Haldane effect. See, left means something negative, no? So we'll put all negative factors. Decrease in CO2, decrease in H plus, decrease in temperature, decrease in 2,3 BPG, and other factors are fetal hemoglobin, because fetal hemoglobin has gamma chains, and fetal hemoglobin has the affinity, gamma chains have a tendency to decrease the 2,3 BPG levels. Okay, fetal hemoglobin, that's why it causes a left shift. And fetal hemoglobin also has a tendency to attach more of hemoglobin. It has more affinity to hemoglobin. Stored blood. See, when you store blood, usually blood is stored with acid citrate dextrose. But when you store it in acid citrate dextrose, this has a tendency to inhibit glycolysis. 2,3 BPG is actually a product of glycolysis. When glycolysis is inhibited, 2,3 BPG is also inhibited. So that is why stored blood, it causes a left shift. But think of giving this stored blood to a hypoxic patient. Already he is in hypoxia, his tissues badly need oxygen, and if you give this stored blood with acid citrate dextrose, oxygen will be bound to hemoglobin. It will cause a left shift only. Nothing will be released to the tissues of that hypoxic patient. So nowadays acid citrate dextrose is replaced by citrate phosphate dextrose, because citrate phosphate dextrose does not deplete 2,3 BPG. So it will not inhibit glycolysis. So if you give that blood to hypoxic patient, It can cause release of oxygen to the tissues and it will be of use to the hypoxic patient. So this is the use of replacing ACD with citrate phosphate dextrose. So this is about the oxyhemoglobin dissociation curve. Adequate oxygen delivery at cellular level is present in which type of hypoxia? Yes, what is the answer for this? So adequate oxygen is present, but the tissue is not able to utilize the oxygen. Histotoxic hypoxia. So we'll see what is that. Different types of hypoxia. Anemic hypoxia. See, from the name itself, anemia. Okay, it is seen in anemia, reduced RBC or reduced hemoglobin or carbon monoxide poisoning. What is the pathophysiology? When you have anemic hypoxia, no hemoglobin to carry oxygen. So due to reduced oxygen carrying capacity of hemoglobin. Hypoxic hypoxia. Hypoxic means no gas exchange at all. That is why you have hypoxia. It is seen in high altitudes, chronic obstructive pulmonary diseases. Histotoxic hypoxia. Histotoxic means tissue is damaged, tissue is toxic. Most common poisoning is cyanide poisoning, because cyanide poisoning has a tendency to or it damages the tissues through cytochrome oxidase. So this cyanide poisoning is going to be a toxin to the tissues. So it is not going to allow the tissues to utilize the oxygen. So it decreases the utilization capacity of oxygen. So how much ever oxygen you give, tissues will not be able to utilize. Stagnant hypoxia. So the flow is stagnant, as in cardiac failure, congestive cardiac failure, when there is, or any kind of shock, when there is no flow, there is no oxygen which is flowing to the tissues. So due to slow circulation, seen in circulatory shock or congestive cardiac failure. Yes, we'll move on to GIT. A 41-year-old patient presented with chronic diarrhea from last 3 months. A D-xylose absorption test will reveal which of the following. See, first of all, what is D-xylose? D-xylose, it is a simple sugar. It is a monosaccharide. Okay, it is a simple sugar. It is a carbohydrate. And for absorption of D-xylose, you need an intact mucosa. You don't need any enzymes for absorption. You need only an intact intestinal mucosa. So whenever your intestinal mucosa is damaged, it cannot be absorbed. So your blood levels of xylose will come down, and your urine levels of xylose also will come down because it is not absorbed properly. So in which kind of disease can you see this? Mucosal disorder. Carbohydrate malabsorption. It's nothing related to fat. Carbohydrate malabsorption due to mucosal disorder, because xylose is absorbed only when there is an intact intestinal mucosa, as in intestinal diseases like 𝗙cie𝗂𝗃. Okay, you can see, you can do this kind of test for the diagnosis. So let's move on to secretions in the stomach. Most important secretion in the stomach is HCl, an intrinsic factor produced by oxyntic cells or parietal cells. And intrinsic factor is important for B12 absorption. Chief cell produces pepsinogen. G cell produces gastrin. D cell produces somatostatin. Enterochromaffin-like cells produces histamine. Somatostatin is a repeatedly asked question because it has so many things to inhibit. Somatostatin inhibits eventually everything. So let's see what all it inhibits. See, it inhibits growth hormone. It inhibits insulin. It inhibits gallbladder contraction. It inhibits gastric acid secretion. It inhibits gastric hormone secretion, VIP, GIP, secretin, motilin. it inhibits glucagon, it inhibits GIT motility. So when growth hormone is inhibited, along with growth hormone, definitely its twin hormone prolactin also will be inhibited. So somatostatin is going to inhibit so many things. So remember all this. HCl secretion. So basically in HCl secretion, it happens in the parietal cell. So inside the parietal cell, CO2 combines with water with the help of carbonic anhydrase to form bicarbonate, which forms carbonic acid, which splits into bicarbonate and H plus. And this H plus is secreted into the lumen through hydrogen potassium ATPase pump. See, potassium is pumped in. And what about the bicarbonate? See, for every H plus which is secreted into the lumen, one bicarbonate goes into the blood. This is important because after you eat food, H plus will be secreted into the lumen and bicarbonate will be absorbed into the blood. That is called postprandial alkaline tide. Postprandial alkaline tide. After you eat, your blood levels of alkalinity will increase. And in exchange for bicarbonate, which moves out of the parietal cell, chloride moves in, and this chloride directly enters into the lumen. And in the lumen, H plus and Cl minus combine to form HCl, hydrochloric acid. And what are the regulators of this HCl production? You have three hormones which regulate this. Acetylcholine, which is produced by vagus, histamine, which is produced by intrachromaffin like cells, and gastrin, which is produced by G cells. G cells produce gastrin. Acetylcholine acts on M3 receptor, histamine acts on H2 receptor, gastrin acts on its gastrin receptor. And these three factors together, they act in a synergistic way to increase acid production. So that is why when you block histamine, H2 blockers, H2 antagonists, which are your ranitidine, famotidine, you can use it in the treatment of ulcer. Or if you block this proton pump, pantoprazole, lansoprazole, that also you can use it in the treatment of ulcers. Basal electrical rhythm. See, this is called BER, and this BER is produced by pacemaker cells, the interstitial cells of Kajal. And the rate of BER generation, it is highest in the duodenum and least in the cecum. Okay, another repeatedly asked question. What is this BER? BER is actually the slow waves. They cannot produce movement. Only this BER, when it reaches the threshold, it is converted into action potential, and action potential causes movement. So this is about BER. And the highest rate of BER is duodenum, least is cecum. Yes, cardiac physiology. So a few important formulas. Stroke volume. What is stroke volume? End diastolic volume minus end systolic volume is called as stroke volume. For one stroke, how much of blood has moved out? So it approximately comes up to 80 ml. Ejection fraction. Out of the end diastolic volume, what fraction moved out? That is stroke volume. So out of the end diastolic volume, how much is the stroke volume? So stroke volume by end diastolic volume. It's called ejection fraction. So comes up to 60 to 65% normal value. What is cardiac output? Stroke volume times the heart rate. The blood that comes out of the heart per pumping is stroke volume. Blood that comes out of the heart per minute is cardiac output. So it comes up to 5.5 liters per minute. And how will you measure this cardiac output? By using Fick's principle. So what is Fick's principle? Cardiac output is equal to rate of oxygen consumption divided by arterial oxygen minus venous oxygen content. And pulse pressure, systolic BP minus diastolic BP is pulse pressure. So 120 minus 80 which comes up to 40. Mean arterial pressure. Mean arterial pressure depends on two factors: cardiac output, which is a determinant of systolic BP, multiplied by total peripheral resistance, which is a determinant of diastolic BP. Or otherwise, the formula is diastolic plus 1/3 of pulse pressure. See, because systolic and diastolic durations are not the same in cardiac cycle. Diastolic is more. That is why the formula is diastolic plus 1/3 of pulse pressure. Normal value is 90 to 100 millimeters of mercury. If radius of a vessel is doubled, then the blood flow is increased by. So this question pertains to Poiseuille's law. So according to Poiseuille's law, the rate of blood flow depends upon the size of the blood vessel. This is a smaller blood vessel which will have a decreased rate of flow, a bigger blood vessel which will have increased rate of flow. So the formula is rate of blood flow is equal to pi into difference in pressure between the ends, delta P, into 4 to the power of radius divided by 8 times viscosity into length of the tube. So ultimately, flow is directly proportional to 4th power of radius. So if you double the radius, it will become, R will become 2R. So 2 into 2 into 2 into 2, 16 times. So flow increases by 16 times. What will happen if you half the radius? Flow will decrease by 16 times. So the answer for this question is, when it is doubled, it will increase by 16 times. Which is true about heart sound. So what about the heart sounds? You have lub-dub. So you have 4 types of heart sounds: S1, S2, S3, S4. Most important are S1 and S2. So S1 is called lub and S2 is called dub. See this lub, lub-dub is important because L stands for, it has a long duration and low frequency. So if you compare S1 and S2, S1 has long duration, see 0.15 second, and low frequency. Dub has shorter duration, higher frequency. And what is S1 due to? Closure of AV valve. What is S2 due to? Closure of semilunar valves. So the answer for the question is B. And about the ECG waves. So in ECG waves, let's learn the normal waves first. P wave, which is due to atrial depolarization. QRS, which is due to ventricular depolarization. T wave, which is due to ventricular repolarization. See, how will you easily remember this? The atrium, see, this is the atrium. It will depolarize and repolarize. Ventricle will depolarize and repolarize. First event is atrial depolarization. First wave is atrial depolarization, P wave. Atrial repolarization does not produce any wave because it is masked by the following big QRS complex. Ventricle depolarizes. It produces the next wave, QRS. Ventricle repolarizes. It produces the next wave, T wave. So this is how you will correlate the electrical events of action potential and ECG, because ECG is basically the sum of action potentials. And you have segments and intervals. So you have 2 segments, PR segment, ST segment. Segments are flat lines in between. Okay, they are straight lines. And why is PR segment flat? Because during PR segment, the impulse is going through the AV node. Because of the AV nodal delay, it is flat. Why is ST segment flat? See, where is ST segment? Between QRS and T wave. QRS is ventricular depolarization. QRS is ventricular depolarization. T wave is ventricular repolarization. In cardiac muscle, cardiac ventricle, depolarization and repolarization. In between, what do you have? a plateau phase. This plateau only is responsible for this flat ST. So now you understand why ST is flat? Okay. Intervals. You have two intervals, PR interval and QT interval. And PR interval, it starts from the beginning of P wave and it ends after the P wave. So how will you remember PR interval? See, remember intervals as the PR segment along with its wave. What is the wave? P wave. PR segment along with P wave is PR interval. ST segment along with the two ventricular waves. What are the two ventricular waves? QRS and T. So ST segment plus QRS plus T wave is QT interval. ST segment plus QRS wave plus T wave is QT interval. Whereas ST segment plus P wave is PR interval. PR interval varies between 0.12 to 0.2 seconds and QT interval varies between 0.35 to 0.43 seconds. And at the end of S wave, you have a small point called as the J point. So what is the importance of this J point? See, J point is used to study ST segment elevation and ST segment depression. See, in case you have an actual ST segment elevation, J point will move up. In case you have an actual ST segment depression, J point will move down. With J point only, you will be able to identify ST segment elevation or depression. Okay. Sometimes in the place of J point, you can have a wave which is called J wave. What is the other name for J wave? Osborne wave. It is seen in hypothermic patients. So this is about the waves. There's a Kuti wave called U wave. See. So what is this U wave due to? T wave is ventricular repolarization. As a last part of ventricular repolarization, papillary muscle will repolarize. Papillary muscle will repolarize. So U wave is normal. If you see a U wave following a normal T wave, it's absolutely normal. So a quick review of the abnormalities of the waves. Yes, any query? Very, very nice lecture. Thank you, Dr. 𝗏𝗏𝗃𝗃𝗃. So P wave abnormalities. Let's see about the abnormalities. Tall P wave. See, when will you have a tall P wave? As in this right ventricular hypertrophy. I'm sorry. Right atrial hypertrophy. When will you see wide P waves like this? Left atrial hypertrophy. And tall P waves are called as pulmonale and wide P waves are called as mitral. And when will you not see a P wave at all? Atrial fibrillation. See, when your heart is fibrillating like this, there is no time for the atrium to get depolarized. Atrial depolarization will only produce P wave. When your heart is fibrillating like this, no time to produce depolarization. So no P wave at all. Atrial fibrillation. QRS. When will you see a wide QRS? Wide QRS is seen in Ŵlff-Parkinson-White syndrome. What is Ŵlff-Parkinson-White syndrome? See, WPW syndrome is whenever you have an aberrant pathway or an accessory pathway, abnormal pathway, ectopic. So it goes like this, and ectopics have, or the aberrant pathway has a tendency to produce very fast conduction. And this conducting pathway in Ŵlff-Parkinson-White syndrome is called bundle of Kent. It conducts at a very fast speed. So when it conducts at a very fast speed, some portions of the ventricle will depolarize earlier. That is why the depolarization of ventricle shifts from this blue point to this red point. That is why it widens. So in WPW syndrome, first finding is wide QRS. Number 2, because of widening of QRS, PR is going to shorten. Short PR. And because of all this, you see delta waves. So all these findings are clinically talking about 𝗵𝗵_Parkinson-White syndrome. What about T waves? So you can have tall T waves, two types of tall T waves. Tall tented or peaked T waves are seen in hyperkalemia. See, as in this, like a tent. Broad-based tall T waves are seen when you have ST segment elevation. Along with that, T wave also can be elevated. That can be seen in myocardial infarction. PR interval. PR interval can be shortened in WPW syndrome and prolonged PR interval. See, what is the actual problem in uh, or what is the normal finding in PR interval? The impulse is passing through the AV node. So when you have a block in the AV node, PR interval will be prolonged. So AV nodal block or heart blocks, or it's called complete blocks, or any kind of heart blocks can result in prolonged PR interval. Yes, next let's move on to the last topic, endocrinology. So in endocrinology, three hormones are more um, frequently asked in your exams. So we'll discuss that. And actions are only more confusing. So I'll discuss the actions of three important hormones: growth hormone, thyroid hormone, and cortisols. So how will you easily remember? Actions of growth hormone: before fusion of epiphysis, after fusion of epiphysis. So before fusion of epiphysis, growth hormone increases the proliferation of chondrocytes. Increases the proliferation of chondrocytes. When chondrocytes increase, they will increase the height. See, that is why when you have increased levels of growth hormone before puberty or before in fusion of epiphysis in childhood, the person is tall. That is called gigantism. After fusion of epiphysis, after fusion of epiphysis. See, once the epiphysis has fused, now if growth hormone levels are increasing, it cannot change the height because already the person is grown up. It cannot change the height. So it increases the soft tissues, increases size of viscera, organomegaly. It increases the size of hands and feet. So all this together is called as acromegaly. So that is why acromegaly patients will have organomegaly, big hands, big feet, protrusion of eyebrows, protrusion of the jaw. What are the other actions of growth hormone? And how can you easily learn this? Remember, for growth, what all you need? You need proteins for growth. So growth hormone causes protein synthesis. You need electrolytes for growth. So it pushes electrolytes into the growing tissue. From the kidneys, it pushes electrolytes to the growing tissues. And for growth, you need energy. And this energy comes from fats. When fats are broken down, they release free fatty acids, which are broken down into ketone bodies. That is why growth hormone has ketogenic effect. That is called ketogenic effect of growth hormones. And one more thing about growth hormone is that it will not use carbohydrates for energy. So carbohydrates are spared. So when it does not use carbohydrates for energy, excuse me, it does not push glucose into the cells. Therefore, blood glucose level rises. This is called hyperglycemic effect. hyperglycemic effect. So these are all functions of growth hormones. So remember growth when you want to know about the actions of growth hormones. Actions of thyroid hormones. See, thyroid hormones, it increases all rates in the body. Okay, just remember this, all rates in the body. What all rate? It increases brain growth rate, it increases bone growth rate, in heart it increases heart rate, and in lungs it increases respiratory rate, and in the periphery it increases rate of conversion of carotene to vitamin A. So when this increases in hypothyroid patients, that is why, see, you can correlate all this clinically. Hypothyroid patients, mentally retarded, because thyroid hormones increase the brain growth rate. And hypothyroidism, bradycardia, hypothyroidism, the rate of conversion of keratin to vitamin A is affected. Therefore, keratin deposits over the skin, giving you yellowish pigment. Hypothyroid cretins are dwarf because thyroid hormone is important for bone growth rate. And in the ankle or knee or whatever it is, it increases the rate of stretch reflex, increases the rate of stretch reflex. So that is why hypothyroid patients will have sluggish reflex. And in muscles, it increases the rate of proteolysis. So that is why hyperthyroid patients, there is more proteolysis resulting in muscle weakness. That is called thyrotoxic myopathy. Thyrotoxic myopathy. And in GIT, it increases gastric motility rate. So that is why hyperthyroid patients have diarrhea and hypothyroid patients have constipation. And in adipose tissue, it increases lipolysis, increases the rate of lipolysis. So some of you are asking how long the class will continue. Yeah, it's going to be done. We'll finish it now. Rate of lipolysis. That is why hypothyroid patients have increased levels of cholesterols. And overall, thyroid hormone increases the basal metabolic rate, BMR. When basal metabolic rate increases, it tends to produce a lot of heat. That is why hyperthyroid patients are heat intolerant and hypothyroid patients are cold intolerant. And when you increase the basal metabolic rate, oxygen consumption increases. That is called calorogenic effect. And when basal metabolic rate increases, there is weight loss. When all metabolism is happening, there is weight loss. That is why hyperthyroid patients have more of weight loss. So this is about thyroid hormones. It increases all rates. What about cortisols? See, cortisol, excessive level causes Cushing syndrome. The features of Cushing syndrome can be compared or learned along with effects of cortisol. So what is the effect of cortisol on brain? It increases EEG, effect of cortisol. That is why Cushing syndrome patients have psychosis. And whenever cortisol is increased, Androgen also is increased. Androgen also is increased. That is the reason for hair thinning, hirsutism, acne, plethora. And cortisol, when present in excess levels, will have aldosterone like activity. What is the function of aldosterone? Salt absorption and hypertension. So that is the reason for hypertension. And when you have salt absorption, along with that, you will have water absorption, resulting in edematous face, moon face. And cortisol increases gastric acid production. That is why you have peptic ulcer. And cortisol, it has effect on bones. So what are the effects on bone? It causes fractures, osteoporosis. All this is because cortisol increases osteoclast activity and it decreases osteoblast activity. And cortisol, it has a tendency to cause increased proteolysis. So when you have increased proteolysis, proteins are broken down, and proteins are broken down into amino acids, and amino acids form plasma proteins. So Cushing syndrome patients will have elevated plasma proteins, and amino acid can be used for the synthesis of glucose also in the liver, and this excessive glucose is the cause for hyperglycemia. And another effect is cortisol causes lipolysis. Fats are broken down. See, when fats are broken down, they are broken down in the periphery and deposited in the center. So it is taken to the center, deposited in the abdomen. That's why it results in centripetal obesity. And when you have excessive fat deposition in your abdomen in the subcutaneous tissue, it will stretch the skin, resulting in striae. And cortisol has a tendency to decrease gonadotropin releasing hormone. That is the reason for menstrual disturbance. And cortisol has a tendency to decrease the inflammatory response. So that is why wounds never heal. And cortisol has a tendency to decrease fibroblast proliferation. Fibroblast proliferation. That is why it causes consistent bruising and non-healing of wounds. So actions of cortisol along with Cushing syndrome. Yes, we have come to the end of the session, and I hope it was a very long session, but let me know if it was a useful session in the chat box, because since long time I haven't seen any chat there. So thank you all of you for your patience. It was a long hours of class, but still I hope it was a useful session for you. And I would like to end this session by saying just three things to you. Trust yourself. Okay, first thing, trust yourself. You know more than you think you do. Never underestimate yourself. Okay, first thing is trust yourself. Second thing is trust the examiner, because the examiner is going to, you believe that the examiner is going to ask questions only from the book which you have read, and questions from only from the class which you have attended, and questions from only from the app that you have enrolled. So have that belief. First of all, he's not going to ask anything from Mars. So believe in the examiner. So third thing is believe in God, because God will always give you more than what you deserve. Success can be delayed, but God will never deny you of success. So wishing you all the very best. We'll end this session. So hope the magic happens to all of you on the day of your exams, and hoping to see you with flying colors. Thank you all of you. Stay safe. Good night. Yes, thank you all of you for your positive comments for the class. Thank you so much. This is what keeps us driving. Thank you.